Well, good morning to everyone. Welcome to our council members. Welcome to the 112th meeting of the National Advisory Council for Nursing Research. A special welcome always to our council members and to the entire NINR science community. So council members, we do ask that you keep your cameras on throughout today's meeting. The meeting is being videocast and will be archived on the NIH Videocast website. So again, thank you everyone for joining us today. So before we get started, I am sad to share that Dr. Claire Fagan passed away earlier this month at the age of 97. We did want to take a moment to acknowledge the huge contributions she's made to the field of nursing and nursing research. She was a nurse, educator, nurse scientist, nursing advocate, and also one of the first women to lead an Ivy League school, serving as interim president at Penn. Few nurses have had as far-reaching an impact as Dr. Fagan. A member of the first generation of nurse scientists, she undertook research to improve patient care, pioneered landmark baccalaureate and doctoral programs to educate the next generation of clinicians, transformed a small nursing school at Penn into one of the field's preeminent research and training institutions, and served as president of the National League for Nursing and as advisor to the World Health Organization. She also had a connection to NIH as a whole. In 1951, she became a researcher at the Clinical Center, and when the National Institute of Mental Health established a clinical research facility in 1953, she was its first director of children's programs. She was dean at the University of Pennsylvania School of Nursing and named interim president of the University of Pennsylvania in 1993. In 2006, Penn renamed its nursing education building the Claire M. Fagan Nursing Sciences Building. Well into her 90s, Dr. Fagan continued to write and speak about the importance of the nursing profession. At Dr. Fagan's death, she and Dr. Linda Aiken were at work on better ways to encourage nurses, physicians, and other healthcare workers to speak as one on matters of public health. So again, we mourn Dr. Fagan's passing, and we did want to share that sad news today. We have, it turns out, two ad hoc members joining us today. Dr. Jing Wang is Dean and Professor at Florida State University College of Nursing. Her research uses technology to optimize health interventions and improve patient-centered outcomes in chronically ill and aging populations, especially among rural and underserved populations. Dr. Marie Lynn Miranda, something came up for her this morning and she was not able to join at the last minute. But I am also pleased to welcome Mr. Joseph Harrington, who is a seasoned executive with over 3 decades in management and leadership. He brings with him a wealth of knowledge and experience in education, social services, public health, and healthcare. He serves on the board of Cook County Health and is the co-lead of the Patient Community Advisory Committee of the Chicago Area Patient-Centered Outcomes Research Network, referred to as Capricorn. So now I will turn the meeting over to Dr. Elizabeth Tarlov, Council's Executive Secretary, who will proceed with meeting logistics. Dr. Tarlov.
Good morning and welcome. Good morning. Good morning and welcome. I will now do a roll call of full council members to ensure we have a quorum for today's meeting. Council members, please say present or here when I call your name. Dr. Atkins.
Here.
Dr. Ayala,
Here.
Dr. Beckemeyer,
Present.
Professor Dawes,
Present.
Dr. Fitzpatrick,
Present.
Dr. Johnson,
Here.
Dr. Lee,
Present.
Dr. Monroe,
Present.
Dr. Provencio Vasquez,
Present.
Dr. Stone,
Here.
and I note that Dr. Sullivan is present as ex officio for the Chief Nursing Officer, Department of Veterans Affairs, and Lieutenant Colonel Gardner is present as ex officio for the Assistant Secretary of Defense for Health Affairs. Dr. Zank, we have a quorum for this meeting. I'll now turn to a vote on minutes from the last council meeting. Minutes of the September meeting were made available in the electronic council book for your review. May I have a motion to approve?
Move to approve.
Oh,
I'll second if whoever that is wants to approve.
I approved.
I second.
I move to approve, Elizabeth.
Thank you. Any discussion? Any opposed? Motion carries. On meeting logistics, please turn off your microphone when not in use. This is a one-day meeting. As always, a recording of this meeting will be made available at the address shown on the slide. Closed session will begin approximately 15 minutes following the end of open session. Next slide, please. Dates for future council meetings are listed on the NINR council webpage as well as in the open session materials in the electronic council book. Please add these dates to your calendar. Our next meeting is scheduled for May 23, 2024. This will be an in-person meeting here in Bethesda, Maryland. I want to remind council members other than ex officio that you are special government employees. As such, you may not engage in lobbying activities while receiving pay from the federal government. Further information regarding conflict of interest and confidentiality requirements are posted in the electronic council book, so please review those if you haven't done so already. I will give more specific instructions about conflict of interest and confidentiality at the beginning of the closed session later this afternoon. Now I'll turn it back to Dr. Zank for the NINR Director's Report.
Thank you, Elizabeth. So, yes. Okay. All right. Let me start again. Turn on your mics. Got it. Okay. So thanks, Elizabeth. So as we discuss the current happenings at NINR this morning, I think you will see the pivotal role that we are playing in the research landscape, both within NIH and more broadly. Our investments in advancing science, we think, are paying rich dividends, as you'll see with our current and future funding opportunities. In addition, sharing NINR's mission and approach continues to be one of our priorities. So we're excited about the science that we are funding and conducting, and we're always looking for new ways to reach the right folks at the right time and with the right information. So the director's report is developed to provide all of you with an overview of the activities at NINR since our last meeting. And while I think the time is really well spent, if it's only me talking, it really is a lost opportunity. So we're hoping to include more time during these meetings for dialogue. So we value your input, and we really would be remiss if we let the chance to hear from you as experts pass us by. So to that end, we have added time for discussion at several points during the presentation. So we prepared a few questions for the group, and I encourage you also to add any questions that you have for us. There will be plenty of the time at the end for us to talk more. Hopefully this format will encourage us to have more conversation, but this is new and we are experimenting with this new format to make, this dialogue happen. So we'll see how it goes. Curious about your input. So it's been 1 year since we announced firearm injury prevention as a strategic imperative, and I'm really pleased to report that we have made significant progress in achieving our goals. This includes new funding opportunities, grants in progress, and results from previously funded work. At our last council member, I announced the T32 administrative supplement awarded to Columbia University, and I shared 2 forthcoming funding opportunities that further expand our efforts in this really critical area. So first, as you may recall, to advance science and incorporate the unique nursing perspective in prevention efforts, we released the Firearm Injury Prevention Research in Community Healthcare Settings, RFA. And in November, to address our parallel goal of creating a cadre of researchers prepared to do this complex work, we released a funding opportunity to solicit applications to establish short courses in firearm injury prevention. Deadlines from our first round of funding for both of those initiatives have passed, and a second round of applications are due in late spring or summer. Now, these NOFOs have garnered quite a bit of interest and attention, both within our NINR research community and with potential new investigators and collaborators. Our work in this area is not limited to projects funded by those opportunities, though. To further expand our reach, NINR joined the Office of Behavioral and Social Sciences Research Community Firearm Violence Prevention Network as a participating institute and funded a study testing a comprehensive approach to hospital-based firearm violence programming at the University of Texas Health Science Center at Houston. These programs, we know, seek to prevent re-injury in those most vulnerable to firearm injury or firearm-related death. This particular approach was designed with a health equity lens and an emphasis on minoritized racial groups. It will integrate evidence-based programming from the community with hospital efforts. The study also aims to address the existing hospital culture with education on equity and trauma-informed care. Investigators will use a systematic approach to develop and rigorously evaluate this ambitious project. Finally, our investment in firearm injury prevention research has started to produce results, and NINR-funded researchers are leading the way. At our last meeting, we told you about Dr. Sing-Fang Shea's study on racism, firearm injury risks, and mental distress in Asian Americans. Since then, they have released some of their early findings. Dr. Shea and colleagues have reported racism aimed at Asian Americans was associated with increased mental distress and carrying and using firearms, and that those associations were even stronger post-COVID-19 pandemic. And mental distress mediated the link between racism and carrying and using firearms, but this mediation was found only during the COVID-19 pandemic. So we're also very excited to announce that Dr. Shea won the Equity and Justice Award at the National Conference for the Prevention of Firearm-Related Harms in Chicago last year. We will be returning to our efforts related to firearm injury prevention later in the meeting with a presentation of a new concept entitled Expanding Research Capacity in Firearm Injury Prevention. The purpose is to build capacity in nursing science for conducting rigorous, high-impact research in firearm injury prevention through the creation of infrastructure and research resources and support of small research awards and investigator training. So more to come on that. Needless to say, advancing the science is at the core of our mission. This takes multiple forms, including investments in both science and scientists. We have made great progress in our efforts to support projects that produce new knowledge and those that provide training for current and future researchers. Our extramural and intramural programs work together to advance nursing research. So NINR continues to release new funding opportunities to move our priorities forward. The following examples provide a snapshot of our activities in this area. Since our last council meeting, we're excited to share that we re-released an RFA for the Bridge to Care initiative. In 2023, we funded 4 innovative projects totaling over $5 million for innovative community partnerships to address unmet social needs in individuals and families or adverse social determinants of health in communities. The funded projects propose bridges in many capacities, including revising the clinical cascade at the system level to improve access to the treatment of opioid use disorder as people transition from incarceration directly to the community upon release. Improving the accessibility of crucial early childhood special education services through Preschool and Me, a program for Black, Hispanic, and low-income children with developmental delay and disability, and increasing school attendance and ultimately improving health and well-being for children and families using a school-based community health workers in the Health Equity and Rural Education, or HERE, clinical trial. These projects illustrate some of the incredible potential that we at NINR have to address complex health challenges when we actively apply the health equity and social determinants of health lenses to our research. We hope to support equally exciting research in our next round of funding. Those applications are due on March 22nd. So as mentioned at September's council meeting, we published an RFA for short courses in social determinants of health education for nursing research. This supports nursing research education activities in support of the mission of NIH and aligned with the strategic plan of NINR. The first round of applications were due earlier this month in January, and the next and final round is due in July. So we received a very encouraging response in the proposals we received to date, and we're expecting even more in the second round. So I look forward to telling you more about new awards at our next meeting. So this is a good place for us to pause and open the floor for discussion about NINR funding opportunities. So I'll pose a question, but feel free to chime in with anything on your mind, any questions you have as well. So first, just to get us started, what suggestions do you have for reaching the right audiences for funding opportunities and for encouraging applications? You know, we're really curious about what ideas you have for us. I'll open the floor.
Well, I'll start unless anybody else wants to. This is Guadalupe Suchiayala from San Diego State University. Good morning, everybody. Good afternoon, wherever you may be. Can I make a few comments about what you just discussed, because it sort of is related. First, I really appreciate the firearm injury research that's being supported and really the potential impact that it can have on our society. So thank you very much. I'm going to come back to that, but more from a mechanism perspective. But I want to next talk about the focus on education in the bridging to care, because I think one of the things that the focus on just understanding social determinants has made me worried about the exclusive focus on just understanding a problem, but not being able to figure out how to address it. And the crisis that we are experiencing because of COVID-19 and the impact that had on education and the educational impact that this is having now on this generation or multiple generations. So thank you for having that focus. To get others involved, you know, what's really interesting is I am a professor in the School of Public Health, for those who don't know me as well. But my family is a bunch of educators and my brothers are in education, and it's always interesting to me why our fields don't cross more often, given the importance of education to health. And so there are all kinds of venues that could be explored to bring on more education researchers to collaborate with public health researchers. And maybe there's someone on this call that has some solutions there, but that's one thing that one avenue to explore to address your comment, Shannon.
Yeah, thank you so much. Other thoughts?
Yeah, I can. This is Betty Beckmeyer at the University of Washington School of Nursing. I have, not so much a great idea, but a thought or a comment, and that is, first off, I love all of this, and I've mentioned this before, but these are such amazing, important additions and changes to how we're framing nursing science, and I love it. But it also means we need to be training and developing new investigators that can really do this kind of work. It's a really new and different way of thinking for a lot of, traditional nursing science. So I love that there's this emphasis on training. At the same time, I'm thinking, and I'm maybe putting this out to the rest of the group, that one thing I'm seeing quite a bit, and I'm in two schools, I'm in a school of public health, a school of nursing, and I see it in both, whereby junior faculty are just not getting as much mentorship, nowhere near as much mentorship from senior faculty because people just aren't present, right? Junior faculty just don't have the luxury that I did when I was coming up through the ranks in terms of mixing it up with faculty and brainstorming ideas in the same way, or in the lunchroom, or in the kitchen or whatever. So I think about could we think about enhancing or assuring that these training opportunities have build in the kind of mentorship that's going to have to be done in new and different ways. Because I'm seeing junior faculty really kind of scratching their head in terms of how do they reach or get the benefit of senior faculty. So I think along with this training, can we think of sort of new ways to assure that they get that? Does that make sense? I'm sort of thinking out loud, and I hope folks don't mind that, but I'm just putting that out there.
So I hear you. Well, first I'd say, Dr. Ayala, I agree about, educators, right, being an important partner for us in our efforts. And then, Dr. Beckemeyer, so are you saying, the training courses, right, are a step, but unless there's mentorship to sort of move it along past then, right, it may not be as effective as we hope.
Right. How do we complement that? The training is amazing. It's really important. We've got to have it. And how do we complement it with new and different ways of assuring they've got the mentorship?
I definitely agree with that comment, Betty, especially the premise for why not having enough senior mentors, because that's a huge issue in some of these larger network-based efforts that are being funded by NIH that are that's one of its purpose is to build researchers from within. So, but there are few senior mentors.
Does anyone want to hop in on that? Otherwise, we'll move forward, and again, we'll have other opportunities for folks to jump into. Okay. Dan, all right, great. Thank you. So we are, as I mentioned, always looking for ways to expand our reach and build on the really great work already being done by our grantees, and to leverage our resources to really increase our impact. So collaborating with other institutes on research and training initiatives helps us to do that. So we've signed on to over 20 notices of funding opportunities since September, and the following examples illustrate the importance of these collaborations. So as part of the Improve initiative, we collaborated with the Office of Behavioral and Social Sciences Research and several other institutes and centers to release 2 new training opportunities on intimate partner violence, or IPV, among pregnant and postpartum people. The research is very clear about the risk. IPV is a leading cause of maternal mortality and other non-fatal health outcomes. Homicide is a leading cause of death for pregnant people, and IPV increases the risk of homicide and suicide around pregnancy. The complexity of this very urgent health issue has made effective interventions difficult to develop and implement, but we know that we need a research workforce prepared to respond to those complexities. So the first training opportunity is a Career Enhancement Award for experienced investigators already focused on reducing preventable causes of morbidity and mortality among pregnant and postpartum individuals. The leading cause of mortality in this population is intimate partner violence. As such, investigators will gain expertise in the research methods, approaches, and interventions used in IPV research. The second opportunity will support courses for skills development in the measurement of intimate partner violence in pregnant and postpartum people. Applications for both of those were due on December 1st, and we are very excited to learn more about those projects once funded. Another example of an opportunity that we've collaborated on is focus on health and healthcare disparities among persons living with disabilities. Its goal is to support innovative examination of or intervention on the causes and factors adversely impacting persons with disabilities at the intersections of race, ethnicity, and socioeconomic status. So the first application due date is just around the corner on February 5th. We are also collaborating with the NIH Office of Disease Prevention and other institute centers and offices to seek applications for a new collaborative research network to test multi-sectoral preventive interventions for health conditions in populations that experience health disparities. The research network funding opportunity encourages research project applications that intervene beyond the individual level and collaborate with 2 or more service sectors such as health, housing, transportation, education. The research network will also include a coordination center that will provide technical assistance related to intervention methodology and facilitate collaboration across projects. I also have some important and exciting news to share about the NIH Transformative Health Disparities Program. You may recall that we are a founding co-chair of this NIH-wide program. It began as a common fund initiative several years ago in response to recommendations from the NIH Unite Committee. And now I am very pleased to report that NINR is leading the next steps in this program. Now, the program supports innovative intervention research projects as originally conceived to reduce health disparities and advance health equity. It also aimed to increase the competitiveness of investigators and expand the research base at minority-serving institutions. The program called for projects with potential for transformative impact and strongly encouraged projects that address community prioritized research questions. So through the program to date, 16 awards have been made, including 4 new awards in 2023 to minority serving institutions, focused on mental health, HIV prevention, and cardiometabolic health. So the Common Fund is a funding entity within NIH that supports bold, collaborative scientific programs. So we are really thrilled to take that program from the Common Fund and help to continue it into a next phase to shepherd innovative, big research ideas that have the potential for major improvements at the individual, community, and system levels. So earlier this week, we published a funding opportunity for transformative research to address health disparities and advance health equity. So we're seeking proposals that emphasize innovation in its way to address social determinants of health. And again, all focused at reducing or eliminating health disparities and advancing health equity. Importantly, the project proposals must demonstrate community partnerships throughout the research process. A dozen additional institutes, centers, and offices have signed onto this RFA, again, as a continuation of the Transformative Health Disparities Program. And this RFA due date is March 22nd. So let's pause and just open up the floor. We really value your help in terms of spreading the word on opportunities for funding at NINR and NIH. Opportunities like the Transformative Health Disparities Program have really quick turnarounds. So we are interested in how we can help us to spread the word about our research programs. So just opening the floor for any thoughts. Thank you, Dr. Johnson.
Hi, these are really exciting, and I'm so happy to see so many of these moving forward and the success thus far. One thing that jumped out at me, and I'm very happy to see the use of the R25 mechanism in several of these instances, and it looks like from what I saw that mostly they're being used for the short course type purpose. But I encourage us to think about a broader use of the R25 mechanism. Other institutes use it more broadly to include short courses, but also to include much more extensive mentoring, I think, which is relevant given my colleague Betty's comment earlier, more intensive mentoring, but also either applied research experiences in the topic area or pilot funding. And so just an encouragement to think about a broader use of the R25 mechanism that can still be very focused on the specific topic, but can give a much more enriched and in-depth training opportunity for early career investigators in that area. But otherwise, everything, I'm very excited to see all this progress.
Thank you, Dr. Johnson. We'll definitely look at that. Dr. Monroe?
There we go. I would also suggest that in terms of dissemination, it would be really useful to use the established kind of networks of the regional societies and national societies. So particularly looking at kind of quick turnarounds, announcements through those organizations might get to at least the academic partners who might be interested in participating in something like that. And they tend to include a very heterogeneous group of institutions. So it might be people who are not on the usual grapevine.
Yeah, thank you for that. Anything else you want to mention? I appreciate your help spreading the word about opportunities. If there are ways we can get the information to you in order for you to take advantage of any networks you have, we're happy to hear what would be helpful as well. All right, well, I'll let that marinate and we can come back to it. So. Okay. So as you know, publications are a really important measure of our impact at NINR. January of just this month, 2024 alone already, we have about 50 new publications from our funded researchers. These results reflect our various interests and the expertise of the individuals and the teams that we're supporting. Additionally, several of the articles speak directly to our newer efforts related to social determinants of health and health equity. For example, in their study of postpartum symptoms, Scroggins and colleagues report that healthcare discrimination, food insecurity, and education, among other factors, are related to high symptom severity and occurrence in maternal postpartum symptoms. Sherman and colleagues explored how stigma, social and structural vulnerabilities, and mental health are related in transgender women. They found that stigma and co-occurring complex social and structural vulnerabilities are related to mental health symptom severity. Their findings also underscore the critical role that racism and geography play in mental health inequities, especially for people in the southern region of the country. So in addition to our extramural activities, our intramural efforts are equally important for advancing science, including through training. Oh, look, we sort of moved forward magically. So in October, our Division of Intramural Research welcomed 20 first-generation college students in nursing programs. The event emphasized careers and social determinants of health and health equity research, with participants coming from groups underrepresented in science. Students spent the day engaging with nurse researchers, listening intently to panel discussions, experiencing a virtual reality grocery store, and actively participating in a speed networking session. Students learned about the history of NIH, NINR's research lenses, career paths, and training opportunities. So we are delighted to have hosted this event in the fall and look forward to next steps. We are also very pleased to announce that NINR Research Fellow Dr. Li Chan Shang was successfully granted a patent in September. It marked the second patent he received just last year. Dr. Shang developed the rapid nucleic acid separation and sample preparation via hollow-centered silica microsphere. This method employed small silica-based glass beads with hollow centers, initially designed for strength and weight reduction in the furniture industry. By coating the surface of the microsphere with nucleic acid binding materials, which Dr. Shang did, they can selectively bind to target DNA and RNA. Subsequently, the buoyancy force propels the nucleic acid molecules to rise to the top of the liquid, facilitating instrumentation-free nucleic acid separation. So this really novel approach holds significant promise, particularly in the realm of point-of-care sample preparation, where simplicity and efficiency are paramount. As an added bonus, the cost-effectiveness of the microspheres makes them suitable for resource-limited environments. So congratulations to Li Chan. We are really working hard to make sure that NINR's message reaches both the existing NINR community and those whose work and interests align with ours, our future community members. So this past fall, we hosted or co-hosted several outreach events to engage with potential partners and collaborators. In October, the Friends of NINR, or FNINR, celebrated their 30th anniversary. For those Wow, I don't know. It's getting excited to move forward. So those who are not familiar with FNINR, they are a nonprofit organization whose vision is to improve health through expanding support for NINR. In conjunction with FNINR celebration, we hosted an NINR Awareness Day, welcoming FNINR board members and ambassadors to the NIH campus. The audience heard from NINR leadership, enjoyed a poster walk by fellows, and engaged with some of our funded researchers on vital topics like maternal health, climate change and health, and firearm injury prevention. The next evening, FNINR held its annual gala in downtown DC. During that event, I presented Dr. Patty Brennan with the NINR Trailblazer Award, a first of its kind. Dr. Brennan, as you'll recall, was director of the National Library of Medicine and PI of the Advanced Visualization Branch at NINR. Her lab's work on immersive virtual reality to help those managing chronic illness was certainly ahead of the curve. And Dr. Polly Joseph, who is involved in our intramural program, received the FNINR Protégé Award. which is for a nurse researcher who shows great promise in advancing science. So we certainly hope to deepen our connection with FNINR, to work collaboratively with them to achieve a shared vision of supporting nurse-led research that results in meaningful and sustained improvements in health of our nation. NINR is also growing and forming important partnerships with associations to engage more of our audiences and incorporate their feedback into our work. So since our last meeting, we've had the chance to expand our reach with several organizations, including AACN and APHA. AACN provided us the opportunity to talk with academic leaders, specifically to explore how we can diversify and expand the cadre of NINR-supported researchers. We held a listening session on strengthening the research enterprise at minority-serving institutions during their annual Academic Nursing Leadership Conference to learn how to better support efforts to build capacity at institutions that have emerging nursing research programs. We had a really fruitful discussion, and the information that we gathered has already been integrated into our DEIA action plan. So connecting with APHA this fall allowed us to share our new strategic plan and emphasize our shared commitment to health equity and population level science. We hosted a networking session at that annual meeting and celebrated the 100th anniversary of the public health nursing section. We were able to introduce members to NINR and our research priorities, share about our collaborative work that we're doing on NIH-wide committees like COMPASS, and speak with members of the nursing section about their interests and their needs related to research funding. Just to keep you in suspense. So we're at another place. We're happy for folks to jump in with any questions that you have. We're really interested, as I said, in finding ways to connect with people whose work aligns with ours, and really interested in any suggestions you have about places, spaces, events where NINR should be. Dr. Stone.
Thanks. This isn't so much about places or spaces where to be, but the theme that I'm hearing, of which I really like, about connecting with minority serving institutions and trying to increase the research and the rigor that comes out of this is really important. And it's super important, places that have PhD programs that don't have NIH researchers at them, sometimes they're not getting the mentorship, and they're not being modeled well. So making those bridges where places that do have the seasoned researchers that can help, I think would be very important, and to think about how to do that. I'm just trying to think of what we can do at Columbia to make that bridge with places, because I do think that supporting things that don't have the strong mentorship and don't show people really what's needed to get it done can be sort of like a false hope, maybe. I'm not sure that's the right word, but anyway, I'd just like to talk, if other people have ideas of what to do and how to do that well, I think it's very important.
Yeah, thanks, Dr. Stone. I think that was a theme we heard when we met with faculty at the AACN meeting from minority serving institutions. They talked about, that it would be helpful to have mentorship in terms of grant writing. So that's something that we're certainly thinking about and would welcome your ideas about as well.
Yeah, and I don't even think it's grant writing. I think it's part of it's grant writing, but the other part is, doing the research and getting it done and continuing to have the team that keeps it going forward. It's the whole process.
Yeah, thank you for expanding that. Dr. Lee?
Yeah, thanks so much. I too was interested in kind of what specific feedback that you had from the meetings with AACN. You mentioned that a few of the recommendations you've already thought about incorporating into the action plan. Can you just give us maybe an idea of what at least one of those was, or one that's a little bit more actionable?
Good morning. So I'm happy to talk a little bit about that. One of the things that they did talk about specifically was the mentoring component, and about making sure that we had a way to connect individuals who were in Research One institutions with those who may not be. But the other component that was really important that they discussed with us was the idea of infrastructure, really setting up the research infrastructure at these institutions where they have the ability to understand not only the research, but how to go about not writing grants, but also mentoring in terms of how do I find the announcements? Who's a program director? When can I go and have a conversation with them? So it was really looking a little bit more at the details and how to make that connection.
Okay, thank you very much.
Okay.
Dr. Zank?
Yes,
I'd also
Professor
like
Dawes.
hello, I'd like to chime in. No, just add that from a historically Black health professions school, Meharry Medical College, along with the other historically Black graduate institutions, there are a number of programs, summits, conferences that we host that I think could be leveraged by NINR to ensure that the information that we're talking about in terms of spaces and places, that information is given to the faculty, the scholars, prospective students who are interested in health professions, especially in nursing. So that would be one that I would add. There's also a network that is being developed by Dr. Donald Warren and Michael Tote regarding Native American, Alaska Native, Hawaiian folks who are interested in health professions. And there is an effort by several other organizations dealing with minority serving institutions that are coming together in light of all that has happened over the last year to ensure that folks have a fair opportunity, to achieve their full potential in terms of educational opportunities. So I think there are a number of opportunities for NINR to leverage from the MSI standpoint.
Yeah, and just to pick up on that, what Dr. Dawes and Stone brought up around the ways to kind of connect these minority serving institutions and the more elite, more resourced institutions. I was at Rutgers, Camden, and now at Hopkins, and it is very stark, the difference in terms of what Dr. Stone brought up in terms of just they don't even know what they don't know. And I think finding ways to kind of find ways that NINR could cultivate these partnerships and make that part of the grant making and allow this process to happen in ways that give them some reps and some sense of like, oh, this is how it works. Because I think it seems so distant and foreign for a lot of these minority serving institutions that just don't have any connection to the NIH and haven't seen it and don't have faculty that have the experience. And if they don't have it, then they can't really share that. So making that bridge and trying to create these bridges, I think, between places like Penn and Hopkins and Yale and all these schools that have, in many ways an embarrassment of riches in terms of what they have in resources, trying to make those connections. So I'm really glad that Dr. Stone and Dr. Dawes brought those, emphasized those points.
Yeah, thank you both for bringing that up. We'll be in touch for sure. I'm sorry, someone else was jumping in.
Yeah, no, I was just to have one counterpoint related to mechanisms, because if I'm hearing correctly, it's the bridge to, say, an R1 institution. As someone who is also a minority serving institution, I have found it more powerful as a minority woman to receive a grant when it to prevent too much of the money going over to the R1 institution when you have requirements that do not allow a partnership with an R1. And so I think just thinking about how money and where it flows is a really important piece to this, because we have been able to leverage so much more while at the same time not destroying the relationships we have with those faculty, because those are really important, but it allowed us to really focus more on our internal needs. and make sure that we're building the infrastructure where the infrastructure needed to be built, is I guess ultimately what I'm trying to say. So.
Yeah, paying attention to how those opportunities are
Yeah.
structured.
Exactly. Exactly. Yeah. So agree with the ultimately. But.
Yeah, thank you. Okay, so let's move forward. All right, so given all the things that we hope to achieve at NINR, we definitely recognize that we need to partner, that it's really so central to achieving our goals. So there are some important partnerships specifically within the federal government that can help us advance nursing science and ultimately, again, really reach our ultimate goal, which is greater health for everyone. So we are really proud to be at the table where conversations at the highest levels of government are being held to develop strategies to improve the health of our nation. In November, the White House released the U.S. playbook to address social determinants of health, and NINR served as the NIH representative to the SDOH Interagency Policy Committee that developed that document. The playbook lays out actions agencies across the federal government are taking to support equitable health outcomes by improving the social circumstances of individuals and communities. The playbook has 3 pillars: expand data gathering and sharing. The Biden-Harris administration is advancing data collection to better address social determinants of health. Another of the pillars is to support flexible funding to address social needs. The administration is looking at how the flexible use of funds could empower communities and improve health outcomes. And then the third pillar is to support backbone organizations. The administration is supporting the development of community backbone organizations and other infrastructure to link healthcare systems to community-based organizations. Now, to accompany the playbook, the Department of Health and Human Services released the HHS Call to Action, addressing health-related social needs in communities across the nation. NINR also serves as the NIH representative to the HHS Social Determinants of Health leadership team. The call to action is meant to encourage partnerships across sectors, which are really important for improving health and well-being for all Americans. Effective primary care is essential for improving healthcare access, the health of individuals, families, and communities, and health equity. So back in 2022, HHS began a department-wide initiative to strengthen primary care. The goal of the HHS initiative was to develop a federal foundation for the provision of primary health care for all that supports improved health outcomes and advanced health equity. The effort involved many of the agencies across HHS, including NIH, and NINR was designated the lead on this initiative for the NIH. We worked with our colleagues at NIH to improve our ability to track research NIH supports in primary care. Specifically, we advocated for and helped develop a new RCDC category in primary health care research. Now, RCDC stands for Research, Condition, and Disease Categorization. It is a computerized, computerized, I think, process used to categorize and report how NIH spends its money. There are more than 280 reported categories of diseases, conditions, or research areas. These data are published each year on the NIH website, and primary care research will be one of those categories now to be reported starting this year. This new code will provide a data-driven estimate of the amount of NIH funding for primary care. So the data for fiscal year 23 isn't posted yet, but really should be in the next couple of months. We also worked with another HHS agency to help them begin the process of tracking primary care research using a very similar method. Last November, HHS released an issue brief on primary care research that lists the department's vision and actions for improving primary care in the U.S., which I hope you will seek out. So we look forward to continuing to play our part in advancing research on primary care. So as you know, in response to the maternal health crisis, NIH launched the Improve initiative in 2019. It aims, all right, we'll go back one. It aims to integrate biological, behavioral, social, and structural factors to improve care and outcomes. So as you know, we are one of the 3 Improve co-chairs. This past fall, Dr. Diana Bianchi, Dr. Janine Clayton, and I wrote a viewpoint for JAMA on the public health crisis of maternal mortality in the U.S. and the Improve initiative. Again, we know the devastating situation we are in with maternal morbidity and mortality, and that much of that morbidity and mortality is preventable. So with Improve, we really want to engage with communities and new partners while trying new approaches. We need new ideas to address this problem. So I invite you to read that entire viewpoint in JAMA. You may recall also that we are collaborating on the Helping to End Addiction Long-Term Initiative. At a previous meeting, Council approved a concept you might remember under HEAL that was led by NINR, focused on the prevention and management of chronic pain in rural populations. An RFA was subsequently released, and I am happy to report that 3 awards have been made to date. 2 are administered by NINR and 1 by NIAMS. The 2 NINR projects are represented on this map by the purple and the red. So both of those studies are testing interventions for pain interference, opioid use, and other HEAL-specific outcomes. Now, the purple is the Reaching Rural Veterans Project. This 16-week, multi-site, pragmatic clinical trial incorporates one-on-one coaching, online education, and group work to teach evidence-based strategies that address substance use disorder as a biophysical, psychological, and social condition. The study will also explore implementation strategies for scaling up across the VA. Now, the red is Enhanced Fitness, a grant to pilot and then test a nurse case management model that includes aerobic and strength training in 6 health systems from 2 practice-based research networks. So we are certainly looking forward to seeing those results from both of those and really all 3 of those important projects. So let me give you an update on the budget. Last week, Congress passed and the President signed a 3rd continuing resolution, extending funding for federal agencies through either March 1st or March 8th, depending on the agency. NIH is in that latter group of agencies, so our funding will expire on March 8th. As with previous CRs, we continue to be funded at fiscal year 23 levels. Now, you may have read that earlier this month, leaders in Congress reached an agreement on top-line funding levels for fiscal year 24. So that's certainly good news, but there's still a long way to go. So we hope you'll stay tuned. Now, I just want to remind you on what's happened so far. Both the House and Senate Appropriations Subcommittees released their own versions of the fiscal year 24 funding bills last year. In the Senate draft bill, NINR received flat funding, as did most of the NIH institutes, with a few exceptions. Now, in the House bill, some NIH ICs received some significant funding cuts, either through the original bill language or in subsequent amendments, and that included NINR. In one of the amendments added to the House bill, NINR funding was cut by $19 million. To date, that version of the final House bill hasn't come to the floor for a vote. Now that the 2 chambers, though, have agreed on a top-line number for fiscal year 24 spending across all agencies, the House and Senate will have to conference and negotiate the final funding levels for each agency. Across NIH, we remain hopeful that we will not be subject to drastic cuts. However, even a flat budget will have significant impact. Great ideas and the potential for new discoveries will be lost. there is real concern that we will lose a generation of early career scientists. So partnership with all stakeholders is really important. So I'm going to move along just because I noticed the time, because then I want to share a little bit more with you about some other events and happenings at NINR and NIH. So first, I'm pleased to welcome more talented staff to the Institute. Nadia Abu Salah started as an operations coordinator. Latasha Whitlow, a management program analyst, and Lee Willis is a program officer, all in the extramural division. Kalina Bauer is a new executive assistant for Dr. Ackland, and Dr. Irwin Liva joined as a visiting postdoctoral fellow. So we want to welcome them all to NINR. In September, we mentioned an NINR-supported investigator, Dr. Deborah Moser, was selected for a very high-profile lecture series at NIH, the Wednesday afternoon lecture series. So we're pleased to report that the details have been announced. Cardiovascular disease disparities in rural America can be viewed on NIH videocast on April 17th. Dr. Moser, you may remember, is Assistant Dean of PhD and Scholarly Affairs and a professor in nursing at the University of Kentucky. NINR was very proud to lead the combined federal campaign at NIH, and we raised I can't remember that number exactly, $2.16 million to benefit over 5,000 nonprofit organizations. The combined federal campaign allows federal employees and retirees to support individuals and communities in need in the U.S. and around the world. As the lead, NINR hosted a kickoff event and held a fall charity fair and directors challenge, in which 28 NIH directors created pumpkin masterpieces. So 3 were selected for first, second, and third places, which you can see were pretty creative. And NINR's pumpkin came in a not too shabby 4th place, all for a good cause. So, and finally, I want to share some news about NIH and from the White House that have implications for our work at NINR. As you'll recall, President Biden nominated Dr. Monica Bertagnolli in May. She was confirmed by the Senate and took office in November as the 17th director of NIH. Dr. Bertagnolli is the second woman to lead the NIH. She previously directed the NCI and has a strong interest in rural health. Dr. Bertagnolli recently articulated her guiding principles for NIH. She shared that NIH encompasses the lab, the clinic, and the community, with patients as partners in discovery. She believes that progress is accelerated when advanced scientific methods such as new data analytics are applied to data that includes everyone, and when discoveries are rapidly and equitably adopted to clinical care. There is also a strong commitment from Dr. Bertagnolli to harness the power of artificial intelligence and machine learning to advance research across diverse fields, diseases, and scientific communities. Ultimately, Dr. Bertagnolli believes, as we do at NINR, that the work is only finished when all people are living long and healthy lives. So we welcome Dr. Bertagnolli's leadership. In November, President Biden named Dr. W. Kimron Rothmill to head the National Cancer Institute, the largest of the institutes at NIH. Dr. Rothmill started just last month. She is a kidney cancer specialist who was chair of medicine at Vanderbilt University Medical Center. She's been on the NCI Board of Scientific Advisors for 5 years, advising on research and operations. So now Dr. Rothmill will be leading the Institute and will be instrumental in President Biden's Cancer Moonshot program, which aims to reduce cancer death rates by half by 2047. I'm pleased to announce that NIH has designated people with disabilities as a population with health disparities. This designation is important because it encourages research related to that population and explicitly acknowledges the well-documented disparities that exist. This official designation and rationale for the change align well with our strategic plan. It also provides new opportunities for our community of scientists to pursue research specific to the health and healthcare of people with disabilities. There are also some very interesting initiatives currently in progress that complement our goals at NINR. Since we last met, the White House announced it was launching its initiative on women's health research, developed to pioneer the next generation of discoveries in women's health by significantly changing how research in this area is approached and funded. The initiative, led by First Lady Jill Biden and the White House Gender Policy Council, will consist of executive departments and agencies across the federal government, including the Department of Health and Human Services. So this action is needed to close the gap on women's health research, spur innovation in the federal government, and improve women's health. So I've reached close to the end here. Just want to pause to ask, what didn't I cover that you're interested in hearing about? And, again, if you have feedback on this format or other ideas to facilitate discussion. So let me just pause briefly. Any reactions you want to share?
Shannon, yes, I do have a reaction, but it's more to related to the discussion quickly. One thing to consider, or I have been wondering about, is equipment-related grants. So I have started to work more to support basic scientists just because of the mechanisms I'm working under, or leading, I should say. There are a lot of equipment grants, and what challenge we have found in doing clinical research with nursing faculty is the lack of IT infrastructure for analysis of EHR data, of exchanging that data, of linking it with other data, of sharing it with repositories. And so I don't know, is that something that could be considered as part of this infrastructure development?
Yeah, thank you for sharing that. I think we're open to ideas and would be curious, right, from others, how they see that fitting into our strategic priorities. And yeah, thank you for sharing that. Anybody have things to add there? Thanks for sharing that, Suchi. We'll certainly think about that here. Okay, so again, I as I wrap up, I certainly want to thank my colleagues at NINR for their help compiling all that data. I also want to thank my colleagues here at NINR and certainly all of you on council for your continued support of the Institute. Feel free to reach out to me. I think everyone has my email, but also at the address here if you have any questions. So looking forward to today's meeting. So I am really pleased to share that Dr. Courtney Ackland has joined us as NINR's Deputy Director since our last meeting. I announced her arrival in October at our September meeting, but she's here. So I've asked her to introduce herself today. Again, she joined us in October from the NIH Office of the Director. I'm going to let her share her background with you. But first, I'll just say just how fortunate we are to have her at NINR, to have her experience, her expertise, and her just who she is and what she brings to us here. Courtney.
Thank you so much, Shannon. It has been an honor, and I am beyond excited to join you today. This conversation that we've already started having in relation to infrastructure, supporting early stage investigators, are all things that I've spent quite a few years championing, working through, but I also recognize that we're a little bit behind on time, so I'm going to keep it really brief. I came to NIH almost 20 years ago as an American Association of Advancement of Science and Society for Research and Child Development Policy Fellow. And yes, it is a mouthful, so we go by AAAS fellows. And over the course of my tenure here, I had many roles, from a program officer with a portfolio on anxiety and fear, to a program director who designed infrastructure initiatives to enhance preparedness for schools that didn't have the research funding to be as competitive for NIH grants, to a chief of staff running an institute's immediate office of the director, communications, and legislation groups. And of course, most recently, in my most recent present job is the acting associate deputy director of NIH. All of these are to say, I'm just really excited to have the opportunity to leverage these here. I'm a clinical psychologist who has been trained and committed to community engaged work from the outset, but also really excited about the place that we're moving in terms of advancing health equity. And again, I'm just really excited that my career journey has led me here. I'm looking forward to working with all of you and getting to know you better, as well as working alongside Dr. Zink and our colleagues at NINR to really realize the advancement of nursing science so that we can optimize health for everyone. Thank you.
Thank you, Courtney. So glad to have you with us. I'm looking forward to being in person in May and everyone having a chance to meet Courtney and interact and get to know her better. So with that, I will turn it over to Dr. Tarlov, who will review our council procedures.
Thank you, Dr. Zank. Each year, council must review its operating procedures for the coming year. The proposed 2024 council operating procedures were provided to you in the electronic council book for your review. The procedures are essentially unchanged from last year. I will now ask for a motion to approve the council operating procedures.
So moved.
Second.
Thank you. Any opposed? Dr. Zank, I turn the mic back to you.
Thank you, everyone. All right, let's move on to concepts. Let's talk about science. So as you know, in your advisory role to the NINR director, you are NINR's source of non-governmental advice on research directions and scientific priorities. NINR seeks council advice for long-term planning at an early stage by presenting concepts for clearance. A concept is the earliest planning stage of an initiative before developing a funding opportunity. A concept describes the background, objectives, and potential mechanisms for the initiative. Any approved concept may or may not ultimately become a funding initiative based on a number of factors, including funds availability. So summaries of today's concepts were made available in the electronic council book for your review in advance of the meeting. So first, our first concept, NINR Program Officer Dr. Karen Huss will present a concept on expanding research capacity in firearm injury prevention. Following Dr. Huss's presentation, Council Member Dr. Pat Stone will offer comments to open the discussion. So Dr. Huss.
Thank you, Dr. Zank. I'm pleased to be here with you to present our concept, expanding research capacity in firearm injury prevention. Next slide. This concept was developed by Lee Willis, Karen Kale, and me. Next slide. Let's begin with some background. Firearm injuries and deaths are a serious health crisis in the United States, unparalleled anywhere else in the world. Although the deaths started on the increase back in 2015, there has been a marked increase in deaths since the pandemic started. In 2022, the most recent year in which we have completed data, there were 48,117 firearm-related deaths. Of these, 56% were suicide, 41% were homicide, and the category other included unintentional deaths, such as law enforcement. Next slide. There are ever-increasing disparities related to firearm injuries and deaths. In 2022, compared to white children and teens, Hispanic Latino children and teens were 4 times as likely, and Black children and teens were 20 times as likely to die of firearm injury. Furthermore, in 2022, for the first time on record, The gun suicide rate among Black children and teens ages 10 to 19 surpassed the rate among white children and teens. Next slide. Impactful research focused on firearm injury prevention is required to influence policy, practice, advance health equity, and is an NINR strategic imperative. Next slide, please. Nursing science and firearm injury prevention. Firearm violence and disparities are complex problems influenced by social determinants of health. Social determinants of health are conditions in which people are born, grow, learn, work, play, live, and age, and are structural factors shaping conditions of daily life. Firearm injury prevention research must hold social determinants of health as a foundation and integrate community needs and perspectives. Nursing science that considers health challenges within the context of social determinants of health is well positioned to make important contributions to firearm injury prevention. Next slide. However, presently there are gaps in nursing science research capacity in firearm injury prevention. There are few schools or colleges of nursing with programs that are focused on firearm injury prevention. Existing firearm injury centers rarely engage nurse scientists. Therefore, there are few opportunities to build the capacity to conduct firearm injury prevention in nursing science. Capacity building is needed in nursing science on firearm injury prevention. Capacity building is defined as enhancing the abilities of individuals, organizations, and systems to plan and undertake and disseminate quality research efficiently and effectively. Next slide, please. The purpose of this concept is to build capacity in nursing science for conducting rigorous, high-impact research in firearm injury prevention through creation of infrastructure and research resources, support of small research awards, and investigator training. Next slide, please. There are several potential research objectives for this concept. For example, develop capacity of nurse scientists and scientists in aligned fields to conduct inter- and transdisciplinary research in firearm injury prevention. Strengthen the capacity for rigorous and high-impact firearm injury prevention research by building and expanding research resources. What are resources? Examples could be to develop a library of outcome measures appropriate for firearm injury prevention research, or build a community advisory or content expert committee available for investigators. Another objective could be enhanced capacity to address firearm injury disparities through community-engaged research, or support pilot and small research projects that will develop new multidisciplinary research teams. Also, foster diversity of the firearm injury prevention research workforce through initiatives to enhance the ability of nurses and other investigators to develop programs in firearm injury prevention. Next slide. These objectives would support early-stage investigators, new investigators, and established investigators who are new to firearm injury prevention. Next slide. Thank you again for the opportunity to share this concept with you. We're looking forward to the discussion.
Thank you, Dr. Hess. As mentioned, Dr. Stone will lead us in discussion.
Thank you. Firearm injury, there's no doubting that with these statistics, how terrible it is. And clearly nursing science has not been focused on it. I think back to some other areas where NINR has really developed capacity in the past, one being palliative care and the other being genetics. And some of the ways that NINR, I don't know what you're thinking about how to develop this infrastructure, but both of those serve as examples of maybe how to build capacity. One is the, not being a geneticist, I'm going to get it all wrong, the genetic, some are program that NINR used to support that brought investigators in to learn about genetics. So something like that. The other is the sort of research consortium that was done with palliative care that was very, very impactful for new investigators that wanted to move in that area, to bringing the resources. I think about those things. I think about with firearm injury not being an area that I've done any, my own work in, how do we bring the resources of the existing firearm centers and the people that are very knowledgeable, like, the head of our, from Penn, Charlie Brand is the head of our epidemiology department now at Columbia, people like that. And I know that there's a firearm injury or firearm prevention conference. How do we bring those people to nursing science? And I think NINR can do something, by bringing these people to set what is the research agenda. I know that the National Academy of Medicine is doing that, and I'm sure Shannon knows about that. They have they're piloting an interest group on that. But how do we get these people to be partnering with nursing scientists and get nursing scientists in the room with them? So you've been very successful with genetics and palliative care, and I think I would use think of some of those successes, how you could do it to firearm injury. And any other questions about that or comments?
I think your suggestion, Dr. Stone, for us to take a look at how they developed the capacity for the Summer Genetic Institute, which was very, very successful, would be something we will definitely look at, because we do have the history on that, as well as your other example as well. We're thinking in terms of potentially looking at initiatives where we can kind of incentivize faculty from multiple disciplines. I think we talked about even having the educators today was one of the disciplines that we definitely need to bring in, but law enforcement, anthropology, bringing the experts that are doing this research currently into together to begin to develop some of this, and then through those resources begin to build the infrastructure for nursing science.
No, I think it's a great idea. And you were so successful with that Summer Genetics Institute. I could see something like that being successful for firearm injury, where you bring the experts in to teach people what's needed in this area.
Other comments from council or questions? Great. Okay. Thank you so much, Dr. Stone. Thank you, Dr. Huss.
Thank you.
We will transition to our next concept. So our NINR program officer, Dr. Julia C., will present a concept on advancing health equity through housing. So following that presentation, Council Member Dr. Elias Provencio Vasquez will offer comments to open that discussion. So Dr. C.
Thank you, Dr. Zink. Good morning, everyone. Today, I will be presenting our concept, Advancing Health Equity Through Housing. Next slide. Our concept team includes both me and Dr. Dion Godet-Greer. I also want to acknowledge Karen Kale, Susan Old, and our leaders, Shannon Zink, Courtney Ackland, and Elizabeth Tarloff, for providing feedback and refining this concept. Next slide. Multiple forms of housing insecurity are currently on the rise. Homelessness has been on the rise since 2017, and the number of people experiencing homelessness rose 12% between 2022 and 2023. According to the point-in-time estimates presented by HUD, on a single night in 2023, approximately 650,000 or 20 in 10,000 people were experiencing homelessness in the U.S. This graph does not show the breakdown of homelessness by sociodemographic groups, and it is important to understand that homelessness does not impact sociodemographic groups equally. For example, people who identify as Native Hawaiian or other Pacific Islander, Black, American Indian, Alaska Native, or Hispanic are overrepresented among people experiencing homelessness. Other groups, such as sexual and gender minority youth and veterans, are also more likely to experience homelessness. Next slide. Other forms of housing insecurity are also on the rise. For example, the number of households with worst-case housing needs increased between 2019 and 2021. Worst-case housing needs is defined by HUD as very low-income renters. These are households with incomes at or below 50% of their area's median income, who do not receive government housing assistance, and who pay more than 1/2 of their income towards rent, live in severely inadequate conditions, or both. As you can see from the figure, the number of affordable and available housing units is decreasing, which contributes to the rise in households with worst-case housing needs. Similar to patterns we see with homelessness, certain sociodemographic groups, including but not limited to most groups of people of color, sexual and gender minority groups, and veterans are more likely to experience housing insecurity. Next slide. Homelessness and other forms of housing insecurity have been linked with adverse health outcomes, including higher rates of physical and mental illnesses such as cardiovascular disease, communicable diseases like TB and COVID-19, and depression, as well as mortality. Next slide. Housing security and quality, along with their upstream determinants such as structural racism, historical redlining, and other policies, are key social determinants of health and drivers of homelessness and health disparities. Lack of adequate housing may lead to or interact with other adverse social determinants of health, including but not limited to poor educational and employment opportunities and lack of access to health care. Collectively, these adverse social determinants of health may not only increase homelessness and housing insecurity, but also a myriad of other social risks, such as low income, food insecurity, and inadequate health care. Through a variety of pathways and mechanisms, housing insecurity, together with concomitant adverse social determinants of health and social risks, leads to increased health risks and health disparities. For example, inadequate housing or lack of housing may lead to environmental exposures and reduced opportunities for healthy behavior, which in turn may increase susceptibility to developing chronic diseases. Next slide. Given the strong associations between housing insecurity and negative health outcomes, interventions to prevent or address homelessness and other forms of housing insecurity have been hypothesized to have positive effects on health. While many housing interventions have been shown to improve housing outcomes, the impact of housing interventions on health outcomes is less clear. Rigorous trials of housing interventions are limited, and current studies examining the impact of these interventions have shown mixed effects on health outcomes. To address the limitations of current housing intervention research, researchers and policymakers have asserted that more research is needed to rigorously examine which housing interventions are effective in improving health, which specific health outcomes they improve, and the mechanisms by which these interventions influence health. Additionally, more research is needed to identify for whom and in what context are these interventions effective in improving health, and more work may be needed to develop or tailor interventions to meet the unique needs of specific subpopulations of people experiencing homelessness or other forms of housing insecurity. Finally, given that people experiencing homelessness or other forms of housing insecurity often experience multiple social risks, more research is needed to determine what types of complementary interventions may be necessary to enhance the health impact of housing interventions. Next slide. The purpose of this concept is to support research to advance health equity through development, testing, and evaluation of interventions to prevent or address homelessness and other forms of housing insecurity. Next slide. Examples of scientific areas of interest under this concept include funding opportunities inviting studies that examine the effect of housing insecurity prevention, this can include homelessness prevention, on health outcomes, examine the health effects of housing interventions among people experiencing housing insecurity, examine the unique housing and social needs of subpopulations of people experiencing housing insecurity, such as racial and ethnic minority groups, underserved rural communities, sexual and gender minority groups, and people with disabilities, to inform the development of future interventions, or examine the effect of interventions designed to meet the unique needs of subpopulations of people experiencing housing insecurity. And finally, examine the impact of housing issues related to housing conditions, quality, and safety within homes on health outcomes. Next slide. Thank you, and I'm looking forward to the discussion.
Thank you. Dr. Provencio Vasquez.
Thank you so much. Thank you for the presentation. When I read this concept paper, I immediately thought about where I live in Denver, Colorado, which seems to be a place where the politicians are taking homelessness and housing insecurity as their platform and their agenda. Denver is one of the top 5 cities in the United States with the highest homeless population. We do have a new mayor that really created this platform on resolution of homelessness in the Denver metro area. The first week in office, he hit the ground running and created interventions to address homelessness in Denver, Colorado. And I'll give you an example of 2. One was giving homeless people $1,000, which he stated would help with decrease in homelessness and increase in employment. Not sure how he got to those results. The other intervention was converting hotels into apartments for homeless individuals. And it seems to be in the news that every week there's a ribbon cutting for a new apartment complex for homeless individuals in the Denver area. None of these, however, are aligned with health outcomes or how it impacts health of individuals that are homeless. A more recent intervention, about a month old here in Denver, was created by Denver Health, which is our safety net hospital in Denver. And they expanded their mission to help with housing for their patients. So what they did was Denver Health repurposed a former administrative building on their hospital campus designated to help patients transition from the hospital into their care within the community. And their purpose was to decrease readmissions of these individuals that are homeless that come for healthcare. So we'll see what the results are with that intervention, and I'm sure they're collecting data to see the impact on healthcare of those individuals. So as stated, this concept paper will address current housing interventions, researchers, policymakers, that has asserted that more research is needed to rigorously examine which housing interventions are effective in improving health. So it'll be interesting to see some of these interventions really more aligned with healthcare and health outcomes. So I'll open it up to my colleagues to see if there's any other thoughts on this concept paper.
This is Capstone. What you just presented makes me think that the research in this area may be best by doing natural experience, natural science, not actually doing a clinical trial, but evaluating what's going on, for a natural experiment. That might be, one of the best ways to really get at how does what interventions really work versus having an intervention where you're actually putting, randomizing people into housing or not, and they're homeless and trying to follow them up. But, I think that, I think with the innovative, I wonder if the $1,000 is going to do anything, but some of the, I think these natural experiments are happening in communities, and we're not. And you said you're sure that the, Denver Health or whatever the name of the organization is following up with the outcomes. I'm not so sure, that, they might not be. They might be trying, but, just a thought, using a natural experiment of things that are already going on.
Thank you, Dr. Snow.
I agree. I think that's a great point. And I think there would be a lot of opportunity potentially for nurse researchers to partner with those who are developing and implementing these housing interventions to evaluate their impacts on health outcomes.
I have a question about what type of mechanism would result from this concept? Is this a concept for an R-type mechanism or a U-type mechanism? Is that known at this stage?
That has not been finalized at this stage, and I don't know if any of our leaders would like to jump in on that response.
I don't think so. Dr. Charlov, do you want to add anything?
Yeah, no, we are really at the beginning of this idea, and part of our purpose here was to put it out for some, early feedback. We are deep into thinking about, what an initial funding opportunity would look like. So we are not at this stage of determining what a mechanism would be.
The reason I ask relates to kind of the goals behind this, and I love the idea regarding natural experiments. But what I also think about is that we see a lot of use discussed during the meeting, and to me that doesn't fit as well to that sort of that type of exploration and research, right? To do a natural experiment under a U. There's so many deliverables with you that it just seems to often conflict a little bit, honestly, with the science. And so, not that it's bad, because I think the U's are better at helping to translate the science towards implementation, sustainment, dissemination. But, I just wonder about that.
I appreciate that feedback. We'll keep that in mind.
Any other comments? Appreciate that feedback. Thank you, Julia. Thank you, everyone, for that really useful feedback and for kicking us off. Dr. Provencio Vasquez, appreciate that. So, all right, our third concept, our last concept for today, NINR Program Officer, Dr. Karen Kale, is going to present a concept on expanding research to advance health equity in rural populations. And Dr. Cindy Monroe, our council member, will offer comments afterwards. So, Dr. Kale.
Thank you very much, Dr. Zank. Good morning. I'm really excited to have this time to share this concept with you. Next slide, please. And want to tell you a little bit about the team that developed the concept. So this team includes Dr. Marina Kubu-Odero, who is one of our Presidential Management Fellows, who's been working in the Division of Extramural Science Programs, along with Drs. Karen McNamara and Julia C., who are two of our newer program officers at NINR. Next, please. So, as you may know, nearly 1 in 5, or more than 46 million Americans, reside in rural areas. Most of you have heard me talk before about the health disparities in rural communities, and it's well established that rural populations experience a higher incidence of disease and disability, higher mortality rates, and lower life expectancies than populations in more urbanized areas. Rural populations also have higher rates of chronic conditions, such as cardiovascular disease, cancer, diabetes, respiratory conditions, and stroke. The COVID-19 pandemic highlighted and exacerbated these existing disparities in rural health, especially for people of color. Next, please. Health in rural populations is influenced by biological, social, behavioral, and environmental factors. Social determinants of health and the wider set of structural factors shaping the conditions of daily life are major drivers of health disparities in rural communities. social determinants of health, including quality and affordability of available food and housing, healthcare coverage, education, employment opportunities that provide a living wage, and transportation infrastructure that facilitates access to resources that are needed to support health and well-being all contribute to rural health inequities. These and other social determinants of health vary across rural subpopulations, such as immigrant and migrant communities and people of color. And we also see variations across geographic areas as well. All of these social determinants of health influence individual and family social risks that lead to the health disparities in rural populations. Next, please. There's been substantial observational research that's documented the impacts of adverse social determinants of health on the health of rural populations. Researchers and policymakers have emphasized a need to focus on solutions to improve rural health. Limited effective interventions addressing some of the health challenges in rural areas are available, but there have been important gaps in their adaptation and implementation that hinder their population level impact. Further, few intervention studies, including NIH-funded studies, have focused on promoting health equity in rural communities. Intervention research, particularly in the areas of maternal health, climate change, and firearm injury prevention, are needed to address NINR priorities. Given the strong body of literature linking adverse social determinants of health and social risks to health disparities in rural communities, future rural health research should focus on interventions that address these social determinants of health and/or social risks. As rural communities are each unique, when possible, researchers should partner with community-based rural organizations to implement interventions that are tailored to those specific rural communities. Next, please. To address these gaps, the purpose of this initiative is to advance solutions-oriented research to improve health and promote health equity in rural populations with a focus on social determinants of health. Next, please. So some examples of scientific efforts that would be of interest under this concept include research that would seek to understand and assess how social determinants of health impact health outcomes in a way that could inform future development and adaptation of interventions. Another example would be development or adaptation and testing of interventions that address rural health disparities. Examination of the mechanisms underlying interventions addressing rural health disparities is also important to inform both adaptation of the intervention for the rural population and future implementation. In addition, dissemination and implementation research is needed to facilitate implementing effective interventions in different rural communities and with different rural populations. Next, please. We're really excited about this concept, and we look forward to hearing from Dr. Monroe and the rest of the council in this next discussion. Thank you.
Thank you, Dr. Monroe.
So I found this concept paper to be really fascinating. I think it's a really important topic that really hasn't received enough attention. And it's particularly near and dear to my heart because I grew up in a rural area, and my very first nursing job, fresh out of school, was as the night nurse supervisor in a small community hospital that served my own community. So I feel like this is a topic that really hasn't received enough attention. And while you noted that there are some observational data available, there really is a dearth of intervention research that really targets the unique situation and conditions of rural populations. You did note, and I think it's important, that rural communities are very heterogeneous. And so there's a significant variability in the size of the population and the geography over which that is spread, in the composition of their population, and in the resources they have available. And I think the other piece that will need to be considered are the challenges that are related to technological capability. For example, limited bandwidth for internet in some rural populations, and the healthcare workforce challenges with a move of people to urban areas for healthcare positions. There's an ongoing challenge for nurses and physicians in rural populations, as well as for facilities to treat those people, despite the critical access hospitals that are available. So I really applaud this. I think it's a very innovative way to look for innovations that will address the unique challenges that rural populations face, and will leverage potential resources to maybe think out of the box a little bit about how those interventions are going to be designed and implemented. One of my questions is that, noting the heterogeneity of these populations and how unique some of their aspects are on a community by community basis, how will the research in specific communities generate interventions under this concept that might either be generalizable to other communities or might be easily adaptable to communities beyond the one that is studied? So I guess I'm asking about that idea of dissemination and implementation and how that will connect to honoring the unique aspects of the communities that are studied.
Thank you for that question, Dr. Monroe, and I'm actually very excited to respond to it. Dr. Zenk has often said we have to think about the end from the beginning. And I think in this instance, that's one of the things that we really would want to put forward, that even if this is one intervention in one community, there always needs to be an eye towards how can it be adapted and implemented, and what are the features? I think that's where the mechanistic piece comes in. What are the features that can be or should be adapted for a different subpopulation, a different geographic situation, different social determinants of health? So thank you very much for the question. It's very much something that's on our mind, that from the beginning, we need to be thinking about how can something that works in this one, perhaps small area, be used in a much larger, more generalizable fashion.
And I think the other thing that may need some thought is related to community engagement, because the types of community-based rural organizations may look really different from those that are in urban settings, and they may be much less formalized than what you find in urban areas as well. So ensuring the community engagement will be a really, I think, interesting piece of this as well. And I would open it to questions from my other council members.
I don't want to stop anybody else, but this is definitely an area of passion for me. Work a lot in Imperial County, which is on the lower end of the agricultural belt in California. And so my first comment in hearing about this, so thank you for even having this focus, but my first comment related to NIH funding and commitment, the biggest issue, but I think has been solved with D&I research and study design changes, is just the inability to have study designs that fit models that were perceived as rigorous enough by NIH reviewers. And it was just always so hard, cluster randomized control trials, making it a little bit easier for us to maintain that rigor to get past study section. But I feel like that's been solved, and I'm confident that that's going to be reflected in whatever is requested in the application.
Thank you for bringing up that issue. It certainly was a huge issue in the past. I think NIH has a number of resources that have helped with that. One of them being the Pragmatic Trials Collaboratory that NINR has been involved in, which provides a lot of resources to help investigators to write those rigorous applications. But thank you for bringing that up, because you're right. It's something we do need to be mindful of from the beginning.
Dr. Sullivan's hands.
Yes, good morning. Thank you for recognizing me. I was wondering if part of this work could include interventions such as telehealth. It's a passion for me as well, living in a very, very small, extremely rural area, and looking at the consequences of healthcare that surround the people that I would live and play with, if you will. So this is very real. And well, I won't go into all the details of the struggles that we face, but I will just summarize in saying it's a 4 to 5 month wait just to go see a gerontologist. And my mammogram was a good 6 months overdue because I can't get in. So it's personal. And so anyway, telehealth, where it's applicable, is that something that would be considered, or is that not novel enough at this point?
I think it most certainly can be considered. Certainly the infrastructure for telehealth has increased dramatically since the pandemic, and we're grateful for that, although there are certainly still rural communities where you're talking about dial-up if you're talking about internet. We're also very excited that the timing of this was excellent. The Advanced Research Projects for Health, or ARPA-H, just announced earlier this month their Paradigm initiative, which is a platform accelerating rural access to distributed and integrated mobile care. So we're actually hoping that we might be able to pick up some natural experiments based off of some of what's happening with this Paradigm program, which is really looking at moving things like imaging into local communities using these mobile units. So it's an exciting time to be bringing this topic up. And as I said, absolutely, I think looking at telehealth, looking at other technologies, as well as some of the movement that's already happening in the field.
Yeah, thank you.
I have one more comment. I have one more comment. If I heard correctly, Karen, there was one of the ideas was related to mechanisms underlying some potential interventions. Are there, maybe this is premature in the whole evolution of NINR, but are there model programs and data in repositories that researchers could potentially use to propose research? Because that would make it so much easier for individuals who don't have current resources.
That's a fantastic question. And I think on some of the topical areas, we're looking at maternal health is the first one I think of. There have been some collections of data that might be useful. On other topics like climate change and health, which is a huge factor in rural communities, we really don't have much data at all. So I think that one of the things that we had discussed here is really the need to have this open to a broad range of topics, but understanding that that means that we may have studies that are at different places in terms of the science, and some may be more preliminary efficacy studies, others may be focused more on implementation, and we're still discussing where and how we can best step into this space.
Thank you.
Don't want to cut off anyone. Does anyone else have anything you want to add for now? Okay, thank you, Dr. Kale. Appreciate you council weighing in with your feedback and ideas. So it is 11:53 Eastern. We are at break time. So why don't we reconvene at 12:25 Eastern? 12:25. Any concerns about that? All right, let's do it. I'll see you in 31 minutes. 31 minutes. All right, thanks everyone. Looking good, looking good. Timely back here. Thank you. All right. Moving into a different part of our agenda, our next speakers are Drs. John Grayson and Betty Beckemeyer, who will share draft recommendations from the Council Working Group on Climate Change and Health. As you know, Dr. Beckemeyer is a member of this council and a professor at the University of Washington School of Nursing and director of the UW School of Public Health's Northwest Center for Public Health Practice. And Dr. John Grayson is the director of NINR's Division of Science Policy and Public Liaison. So Drs. Grayson and Beckemeyer, the floor is yours.
Well, thanks very much, Shannon. On behalf of Dr. Beckemeyer and myself, we're pleased to speak to the Council today about the recommendations that have emerged from the Climate Change and Health Working Group, the group that we were proud to co-chair. And I'll lead off with some background on the working group, and then I'll turn it over to Betty for the recommendations. Next slide. Okay. I know the Council is well aware of this, but just a quick reminder of why we're talking about climate change and health. The effects of climate change have the potential to have a profound impact on our health and quality of life, and in many respects, we're already starting to see the impact in real time. Climate drivers affect health outcomes directly through weather events such as extreme heat, wildfires, droughts, storm surges, and floods. It also acts indirectly through a series of exposure pathways such as air and water quality, food quality, infectious diseases, and massive population displacement events. And these pathways are themselves influenced by environmental contexts related to land use, geography, infrastructure, agriculture, as well as social, behavioral, and economic contexts that create vulnerabilities associated with life stage, gender, poverty, discrimination, and access to care. So some specific examples as we think about climate change in the context of social determinants of health. So pregnant women, older adults, certain occupational groups such as first responders and construction workers, people with pre-existing medical conditions, people with disabilities, children, and indigenous people are especially vulnerable to climate change. The racially discriminatory practice of redlining intersects with climate change and health. Today, adverse historical homeowners loan corporation designations are associated with worse local environmental quality and health outcomes, including increased air pollution, a lack of green space and tree canopy, higher COVID-19 risk, and worsening urban heat. And third, in the United States, the anticipated threats to food production, as well as to food quality and distribution systems, will result in the poorest Americans having to purchase either nutrient-poor but calorie-rich foods and endure hunger in response to rising food prices, leading to micronutrient malnutrition and obesity. So I think we all have some sense that this is going to be a huge problem for all of us, but what do we do about it? We know that more research is needed on how to mitigate the impact of climate change, but where do we start? And from our perspective at NINR, what specific areas of research might we want to support? And that's where this working group comes in. Next slide. I keep forgetting to say that. This working group was established under the auspices of the Council in September of 2023. The group was charged by Dr. Zenk with recommending to the Council future directions for NINR-supported science and climate change and health. And the group was asked specifically to identify pressing research questions that can be addressed using nursing science's multi-level approach to improving health. Next slide. The working group met virtually 4 times between September and November of 2023 to discuss nursing research's potential role in addressing the multiple factors related to climate change and health. During the working group's robust discussions, many potential research topics were noted, and that formed the basis for the recommendations that will be presented here today and in the report. The discussions that the working group had were absolutely fascinating. Everyone was very engaged, brought their opinions to the virtual table, and in the end, we ended up with many more research ideas than we could ever possibly support. But the group did its best to capture many of those ideas within the recommendations, and those are what Betty will cover in a moment. A final report from the work group will be developed over the next several months. But the goal today is to provide the council with the overall recommendations and to get council's feedback. Next slide. So just some very high-level conclusions that came out of the group. They found that nurses and nurse scientists have firsthand knowledge of climate-related health outcomes in the communities and people they serve, that climate change-related health impacts on communities pose a challenge and a topic of great interest for nursing research, with nurses poised at the intersection of science and society to address climate change and health. And overall, the group believed that NINR and nursing science are well positioned to play key roles in this area of research, and that NINR should be bold and creative in its thinking as it considers future initiatives in climate change and health research. I did want to acknowledge the experts who served on the working group, a mix of nurses and non-nurses who were experts in climate change and health, disaster research, public health, many other fields. And I want to thank them for their ideas and for the enthusiasm that they brought to the work group, despite the time commitment. And as I said before, I really enjoyed attending those meetings, and I thank all of these individuals listed here for their efforts. And so with that, I will turn this over to Dr. Beckemeyer, who will present the 9 recommendations.
All right. Thanks, John. And I just want to say John has been a tremendous partner to work with on this. So thank you, John, along with our amazing committee. So we're really pleased to present this draft recommendation. So that's what we're going to be talking about in a minute here. And we really look forward to hearing your feedback. So the working group, we developed 9 broad recommendations that I'm about to talk about here. And within those recommendations, there are many more ideas for specific topics that we won't have time to cover in full today. But I'll be touching on a few of the highlights, and then there will be additional details in a full report that will be released later this year. In not too long from now. So next slide. So the first recommendation, NINR should support climate change and health research that incorporates a cross-cutting focus on health equity, health disparities, and social determinants of health. So this would be things like incorporating health equity and social determinants of health into any research on the impact of climate change. And that was a consistent theme throughout all of our working group discussions. The group really encouraged research focused on understudied groups at particular risk from climate change, such as migrant workers, indigenous populations, and rural populations. So the next recommendation, NINR should support climate change and health research that is a strong focus on multi-level, interdisciplinary, transdisciplinary research across a broad range of settings, communities, and populations. So the work group over and over emphasized that multi-level research approaches are central to climate change and health research. They were not satisfied with a focus on a particular level. They cited the need for well-powered studies focused on implementation. So if we look at it a different way, we all know about the potential impacts of climate change, but how do we proactively mitigate that impact and help others adapt to climate change? They also talked about the need to bring interventions into communities, to settings like schools, clinics, migrant worker camps, faith-based and civic organizations, and that sort of thing. So next slide. So recommendation 3. They thought NINR should support science that investigates the potential impacts of climate change on nutrition and food insecurity in particular, and develop strategies for mitigating these impacts. So the group talked about research that was needed to mitigate the impact of climate change related severe weather, natural disasters, and that kind of thing on food security, supply, and quality. So this could be research focused on, for example, concerns specific to certain communities and populations, such as access to traditional foods, access to public assistance programs, etc. Next slide. So recommendation 4, NINR should support the exploration of strategies for reducing the impact of climate-related disruptions and disasters on healthcare systems and services. So the impact of, for example, severe heat and storms. So the working group wanted research that was around strategies for ensuring continued access to healthcare, particularly for at-risk populations and geographical areas that were more at risk. That could look like leveraging technology such as telehealth, and including the lessons learned from the COVID pandemic as they saw this as an important area of research. Other examples included ensuring access to mental health care, to aid in recovery after traumatic events, and assessing the impact of federal, state, and local governmental policies on health care related activities in the face of disasters. So recommendation 5, NINR should leverage its expertise in developing and testing strategies to build and reinforce adaptation and resiliency in the face of climate change and its impacts. So resiliency was a common topic that came up for discussion within the group, and the group felt that more work was needed in developing interventions and strategies for promoting resiliency in coping with the effects of climate change on health, and that there was a need for this research in communities and populations that were already experiencing disparities irrelevant of climate change. So a specific example came up more than a couple of times that group members mentioned things like resilience centers or resilience hubs, such as heating and cooling centers that provide shelter in extreme weather. So are these effective? How could they be more effective? What do they do for communities? Again, the COVID pandemic was cited as an example of an acute challenge that tested the resiliency of communities and could inform future research. Next slide. So recommendation 6, NINR should leverage its focus on community and population health to work with communities in developing strategies for mitigating the impact of climate change. So to no one's surprise, particularly in light of the NINR strategic plan, and has been alluded to in these other recommendations, that folks really wanted to focus on community and population health and saw that really as critical here. And it has been said other times, for any intervention to be successful, they really wanted there to be community input, and that was needed from the beginning of any such research. This could include partnering with schools, clinics, local businesses, unions, the energy sector, trade organizations. They had a long list. So new and promising models of CDPR, or community-based research, are being used in programs such as Compass, and that could be useful here and leveraging how things could be done in this kind of research. So other research could look at new ways to create thriving communities designed specifically to cope with changing climates, and exploring strategies for designing new built environments, etc. Next slide. So recommendation 7, and hang in with me there, we're nearing the end of these. NINR should support the development of a cohort of trainees and new investigators. So that's kind of been a theme for us today too, with the knowledge and skills necessary to conduct this type of rigorous and high impact research on understanding and mitigating the health effects of climate change. So none of this would be accomplished, everybody understood, without a cohort of scientists who could do this work. And that's why the working group felt strongly that we needed to train investigators in climate change and health. That was critical. There should be funding opportunities for training, workshops, career development. We talked about that earlier today. And in this case, focus specifically on climate change and health research. They also believe that training in this area had to focus across disciplines and on forming multidisciplinary research teams, given the nature of this particular topic. Recommendation 8. NINR should support research to inform policy decisions about climate change and health at the federal, state, and local governmental levels. So the working group was particularly interested in research that could have an impact on policy decisions at all levels of government. They wanted to see more research to understand the impact of current government policy changes, including those made during the pandemic. So that could be kind of like the natural experiments, perhaps, we talked about earlier today. And that much more work was needed to provide better evidence for future policy changes that will inevitably be needed to mitigate the effects of climate change. And last but not least, our recommendation 9, NINR should support research improving the way that climate change and its impact on health are communicated to the public. So we all know climate change can be a very charged topic, but also that the health impacts of climate change are very real. We acknowledge that scientists are often not the best at communicating the purpose and results of their research to the public. So the working group really recommended that NINR support research on how the health impacts of climate change are communicated as a means to improve the public's understanding of the issue, to encourage uptake of strategies to mitigate these impacts, et cetera. So specific topics could be around communication strategies that are adapted for specific cultures or communities, and how to frame these messages across social boundaries, including ideological and political boundaries. So there you have it. Thanks for our last slide. Thanks for this opportunity to share these recommendations. We're very excited about them. We had really outstanding members of our work group. John and I kind of marveled at the conversations every time. They were really exciting, fascinating, inspiring, fun to be a part of. And the working group really strongly believe that nursing science has a big role to play in climate change and health, and that we can make a big difference. So they believe NINR should be bold, as John said earlier, in planning for this type of research, recognizing the challenges our society faces are huge. So that's all from John and I. We're now really interested in hearing what you all have to say.
Yeah, thank you, John and Betty. So Dr. Lee, thank you for kicking it off.
Yeah, so first, to Dr. Beckemeyer and Grayson, on behalf of the National Advisory Council for Nursing Research, I'd like to thank you both personally, but also every member of the working group for their leadership and service in this very important charge. Second, just as a reflection, I think you've really been heard by this council with respect to the need for NINR to be both bold and creative. And I'll come back to that, especially as it considers future initiatives in climate change and as it intersects with health. I love to see the language of the NINR research lenses embedded in the recommendations, especially recommendation number 1, the importance of always considering health equity and social determinants of health as being really paramount in moving this line of science forward. Betty, you mentioned several things in your narrative that didn't quite translate to the slides yet, so we're all looking forward to seeing that in the report. But as you were speaking, I was thinking about a few things that I'll just make as comments and then lead into an eventual question. One, that you mentioned the importance of mental health. And I'd love to make sure that in the report that there's parity between mental and physical health in terms of the impacts of climate change. The other is that you mentioned working with community partners, and one consideration that you might have is in other places in the world, not only are teams of scientists working with members of the community that are most afflicted, but they're also learning from the knowledge and kind of wisdom of indigenous groups and so forth. So in addition to just partnering with, it would be great to actually leverage knowledge and wisdom that comes even from North American indigenous populations on the issues of climate change and the impacts of health, just as a consideration. Recommendation number 7 really stood out to me before we even got to earlier discussions, but particularly with discussions about mentoring and developing the workforce. I think this is another fabulous area where there will be a need for training and development of new investigators, and then maybe supporting the very few nurse scientists that may work in this domain and their ability to mentor. So, with respect to recommendation 7, I'd just love to know a little bit about what the group was specifically thinking about in terms of the training. Were we thinking of like informal training? Were we thinking of intramural training opportunities like replicating the Summer Genetics Institute? Something more extramural and formal like those R25, so short courses, or, notice the special interest for Fs and Ts and Ks and the like. Just something that you can share with us a little bit more specific about what that training might look like.
Yeah, that's a good question. I'm looking back at our, we have a draft report that, was not ready for prime time. And that's where we were drawing some of these remarks. But I'm trying to remember myself now. John, do you remember some more specifics around that?
Yeah, I'd have to go back and look. Basically, I think the answer is all of the above.
Mm-hmm.
Whether it's workshops, short courses, Fs, Ts, really anything is on the table at this point. The overall conclusion was that we need it.
Right, and I just think, pursuant to earlier comments, especially by Dr. Stone and others, this could be an area where 10 years from now we could look back and say NINR really was instrumental in developing this as a new pillar of expertise, and follow that kind of roadmap of success, modified if necessary for this particular context. I'll just ask another quick question then, and then I'll open it up to other members of the panel. Recommendation number 3 is also fascinating to me about the food security, nutrition and food security. And then definitely is related to something we discussed earlier, housing security. So there's so much intersectionality among these different aspects. What made the group pull out food security maybe separately and then with an intentional focus as opposed to other things like housing security that also come along with that?
We did, I know that in our own separate meetings, we talked about that a little bit. Food insecurity came up specifically as kind of a separate topic, and it came up several times and often, and it perhaps was indicative of the nature of the group that was there and with different people's areas of focus and expertise. So it might have been some of that, but that one did come out specifically. So we wanted to make sure and include it. And more so, I think housing would have been embedded more in terms of more some of these general discussions about how to help people mitigate and adapt, et cetera. But food insecurity did come up often and separately, so we wanted to make sure and highlight.
Right. Yeah, and I think we're all looking forward to seeing the report when it's available for our review. And I'm happy to open it up at this point to anybody else that has questions or comments.
Well, one of the two things that stood out for me one thing that stood out for me was related. It seemed like there was a theme around structural or system-based interventions. And so that was really cool because then I thought, wow, we could learn so much about the potential generalizability of these approaches. And I may have just lobbed onto this idea of the resiliency centers and those cooling hubs because of the heat that we experience in Pearl County, the rural community I work with. So super intrigued by that and the potential that could inform other research.
Great. Pat?
Yeah, thank you all. It's a very, very important area that, again, very, very important area. One of the things that's running through my mind is how is NINR with all these important areas, firearm, injury prevention, housing, climate change, and then the other thing that we've heard about potential budget cuts, how are you going to be able to prioritize these? I mean, there are some that seem to have overlap, in some of these areas, but tough choices, really tough choices in in this really difficult time.
I'm happy to jump in. I'm glad you brought that up. You're right. It is tough choices, and this is where we really look to you for your guidance in terms of priorities and, you know, helping us to think about that. So just want to encourage you to feel free to share your thoughts about that as well. It is an issue, as we talked about today.
I think if there's a way to prioritize the training, I think that would be a fabulous start. Because I think there's a little bit of conflict in saying, you know, be bold and courageous, but we don't quite have the capacity to do that or the structure to do that, or even the workforce to do that yet, without relying really excessively on our interdisciplinary partners. There's nothing wrong with relying on interdisciplinary partners for sure. But if this is going to be an area that's nurse science led at some point, maybe prioritizing some educational initiatives at first might be a starting place, particularly if there has to be decisions made.
Yeah, I appreciate that feedback. It's something that we talk about. We've talked about it recently too, and sort of that balance, right? Because it's also a balancing, right? Because we want to show that our science is making a difference in terms of improving health and advancing health equity, and yet, right, we need a workforce, right, trained to, you know, carry out that rigorous and high impact science. So it is a balance. Yeah. Any other questions for Dr. Beckemeyer or Dr. Grayson? Well, appreciate you all sharing those thoughts. And again, I want to step back and thank Dr. Beckemeyer and Grayson for chairing, and the entire working group for their thoughtfulness, for their time, and for really being committed to advise us and, you know, counsel specifically on this area of science. And so we are looking forward, as was mentioned by Dr. Lee, to receiving that report and reading more about your suggestions and recommendations. So thank you very much.
It was a pleasure. So thank you so much for inviting me to do this on the council.
Thank you. All right. Appreciate that. So we will move to our next item on our agenda. Dr. Shalonda Bynum, NINR Program Officer, has joined us. She will share an update on activities related to the COMPASS program, for which you might remember NINR is a co-chair. So Dr. Bynum is a project coordinator for that program. And so thank you, Dr. Bynum. The floor is yours.
Thank you, Dr. Zink. Good afternoon, everyone. So last council round, Cheryl Boyce from NIH Common Fund provided an overview of COMPASS, including the program's impetus, the structure, and the initiatives. She also spent a little time discussing how the various initiatives fit together to support the development, implementation, and evaluation of the community-led structural interventions, which are the center of this program. So since that time, we've had a few important program milestones that I am quite excited to share with you today. Next slide. Before I move into my updates, I would like to acknowledge the visionaries of the COMPASS program, which includes my director, Dr. Zink, and her colleagues at NIMHD, NIMH, and ORWH. Dr. Zink and her colleagues have really worked deliberately over the past several years to create a program that is bold, innovative, and really like no other that NIH has seen before. Positioning organizations that are closer to the problems dictating poor health outcomes among communities to the front line of identifying solutions to solve them is, to me, tremendous progress. I am excited that NINR had a lead role in developing the program and is now leading efforts to see it through successfully. Next slide. So as a reminder, the goals of COMPASS are designed to be accomplished within a 10-year timeframe, which doubles the traditional R01 period. The overall goals of Compass are twofold. First, to catalyze, deploy, and evaluate community-led structural interventions that leverage partnerships across multiple sectors. This goal is primarily focused on the intervention arm of the program and the supporting roles that are needed to facilitate this. The second goal is to develop a new health equity research model for this work across NIH and other federal agencies, which is an internal NIH goal to establish a process and pathway for continuing this work after Compass funding has ended. So essentially, this will entail creating a roadmap for promoting CHESI-like efforts within ICs and across the federal government. So Dr. Zink spoke earlier about Transformative Health Disparities Program, which originated in the Common Fund program, but branched out to NINR as a lead and other ICOs collaborating on it. So this is really to think through what is needed to support this work within specific institutes and centers. Next slide. Again, Compass spans 3 different initiatives: the CHESI, the Coordination Center, and the hubs. NINR has an overall role in managing the program across the 3 initiatives and a more concentrated role in the management of the Coordination Center. Approximately $200 million was invested over a 5-year period to fund 25 structural interventions, 1 coordination center, and 5 health equity research hubs. Next slide. In September of last year, that is September 2023, 25 health equity structural interventions were awarded directly to community organizations to advance structural change to improve health outcomes among populations that have historically been and currently remain marginalized by society. And I'll tell you a bit about these interventions, but we'll first provide updates on the Coordination Center and the Hubs initiative. Next slide. NINR is the managing IC for the Coordination Center, which is essentially the glue that holds the Compass program together through leadership and administration and coordination, data and research training, and capacity building. NINR staff, including program officer, our project scientists, and grants management office, have worked hard to ensure a smooth launch of Compass and to facilitate a successful Compass kickoff meeting with all 25 CHESI awardee teams earlier this month. Next slide. The National HERA is yet another innovation of Compass and will be housed in the Coordination Center. So NINR, along with our other NIH team partners, will play a unique role in shaping the National HERA, a body that will be composed of federal and non-federal partners that we believe will be very instrumental in supporting intervention sustainability. Next slide. So since we last met, the Coordination Center Award was made to Drexel University in collaboration with the University of New Mexico and Mathematica, with Carol Scott and Eberth leading the effort. Next slide. So as you may know, the hubs will directly support the specific needs of their assigned CHESIs by providing tailored scientific and technical support to individual teams and collectively for the 5 CHESI projects that will comprise the hub. So that is the purpose there. Next slide. During our last council, the funding opportunities for the hub initiative was still open. I am happy to report that we received a good response to the call for applications. Applications came in this past October, will be peer reviewed in March, and hopefully 5 hubs will be onboarded in July. So we are making progress on the last initiative for Compass. Next slide. Okay, so now I'll move back up the initiative list to give you an idea of the types of structural interventions awarded under the CHESI effort. Next slide. The 25 awarded CHESI projects cover all 10 HHS regions, including Maine, Alaska, Hawaii, and even Montana, with the largest proportion of awards in Region 6 covering Arkansas, Texas, and New Mexico. We are extremely proud of the geographical reach we've been able to achieve with this program, especially in states where we, the NIH, and by virtue of the NINR, we seldomly see applications. So we are very proud of this map. Next slide. In addition to the wide geographical coverage, we have representation across a wide range of populations experiencing health disparities, with a larger focus on racial and ethnic minority populations and people with lower socioeconomic status. For the specific composition of racial and ethnic categories, 10 applications will focus on Black African Americans and 13 on Latino populations. And these categories do overlap with many projects focusing on more than one health disparities population. Next slide. The 25 awards were grouped into 5 SDOH domains, with many different topics falling under these broad categories, which are neighborhood and built environment, social and cultural context, economic development, nutrition and food environment, and community healthcare access and quality. Next slide. So we are equally happy to report the representation continues with the types of SDOH factors that will be addressed across the CHESI projects. So here again, these categories overlap. However, across the 5 domains, we have pretty good coverage, with the largest proportion in the categories of community healthcare, with neighborhood and built environment and social and cultural context tied at second. So now I'll provide just a few updates of these examples of these different intervention projects. Next slide. So the first project I'll discuss is one awarded to the Wabanaki Public Health and Wellness Organization in Maine, in partnership with Washington State University. So for these interventions, to remind you, the community organizations are the lead, but they also have a research partner. So the structural factors of focus here are food and housing. Within these domains, the team will aim to create a traditional and culturally appropriate food system for Wabanaki families by working across agencies and systems to inform policy change, while also focusing on housing, economics, and recovery issues within the Wabanaki community. Next slide. The second project on my discussion list was awarded to CANA, a California-based community organization who will work in partnership with researchers at the University of California, Riverside and San Francisco. The structural factors here are housing, employment, and healthcare. So the team will leverage ongoing partnerships that they have at the state and local levels to invest in housing, urban gardens, and creating economic opportunities, primarily for Latino and African American populations. Next slide. Next up here is Grupo Nexos, a Puerto Rico-based community organization, and the structural factors of interest here are healthcare, education, and economics. So the team aims to address childhood poverty through a multi-level approach to advance education and healthcare access, particularly, again, for youth. Next slide. All right, so the next award, Achieving Equity in Farmer Health through Community-Led Research, will focus on employment, housing, and healthcare. This intervention will be implemented in Yuma County, Arizona, in partnership with the University of Arizona. The team aims to address labor practices, promote employee-based insurance, and increase housing opportunities for the farm worker population. Next slide. The next award was made to the Yukon Health Corporation. who will partner with the University of Alaska Fairbanks to address food and economics. The intervention will focus on facilitating local food harvesting, processing, and distribution to support access to traditional food among Alaskan natives. Next, yeah. The last study I'll discuss was awarded to Families Against Narcotics to focus on housing and healthcare. This intervention will be conducted in partnership with a researcher at Western Michigan University. The project aims to expand statewide access to crisis services, namely recovery-oriented care, housing, and behavioral health. Next slide. So I've only discussed 6 projects with you today. There are many other unique projects focused on creating a safety net program for income-constrained populations, enhancing educational opportunities for justice populations, policing, and so many more innovations that are leveraging changes in structures, systems, and policies. You can learn more about each of these projects at the QR code listed here. And I wanted, again, to put up this map just to remind you guys of the geographical reach that we've been able to achieve that, again, we are very excited about. Next slide. So I will end by saying that Compass is a tremendous effort that will advance our understanding and pave paths in a number of ways, including understanding the health impact of community-led health equity structural interventions, building a repository of evidence in this space, promoting community organizations and positioning them to be more competitive for other NIH grants through capacity building and training, and by creating models to move us along the discovery continuum more quickly. Also, you may have noticed that I did not mention health outcomes in any of the CHESI descriptions. And this was deliberate because it is our expectation and hope that given the focus on structural change and structural factors at the upstream level, each project has the potential to improve health outcomes across a set of diseases and conditions. It is the role of the Coordination Center managed by NINR to develop a process for creating common data elements that the CHESIs can all agree on. We are extremely excited about the potential of Compass to make lasting impacts on advancing health equity among populations who continue to bear disproportionate burdens of disease. What we learned from this effort, not only at the 10-year mark, but along the way, will add tremendous value to the science of health disparities, and we are very pleased that it is moving along smoothly. Next slide. So in closing, I also want to acknowledge the Compass Working Group, project scientists, and POs for working diligently to realize and implement the vision of the Compass co-chairs, Dr. Zink and her colleagues. Again, I serve as coordinator for Compass, and my colleague Dara, who will be onboarding soon, also serves on the working group. Next slide. So here's the list of the program officers and project scientists who are really the boots on the ground, working hand in hand with the Compass awardees to provide administrative and scientific support. I specifically want to acknowledge the commitment of our NINR staff, Dion, who serves as program officer, and Libby, who is a project scientist. Compass is history in the making, not only for NIH, but for other federal agencies. So what we learn here, again, will provide tremendous value and evidence on what works, what doesn't work in the context of community-led structural intervention. So thank you for listening. And back to you, Dr. Zink.
Thank you, Dr. Bynum. I've asked Professor Dawes to lead us in discussion.
Bynum, thank you very much for this excellent and informative presentation. You know, I too share your applause for this. This is history in the making. I will say that Dr. Zhang, thank you for your bold leadership on this, because this is truly unprecedented. And I believe it is a game changer. And working with the NIMHD and NIMH, two critical agencies as well, who have led on health equity research, I think is a huge plus for us. I appreciate the thoughtfulness of the diversity and the inclusion of different geographic regions and population groups, as you mentioned, Dr. Bynum, who are often invisible or they're missing in these types of efforts. And I'm also, excited to see that we flipped the script where community-based organizations are leading in many of these projects, working in concert with health researchers, with the academic partners. So that was a plus for me in terms of making sure that the people who are closest to the pain and the problems in our societies are the ones who are empowered or given the ability, the opportunity to lead as such. As I was thinking about, this initiative, when I was invited to give remarks, I thought about Dr. King's comments on the heels of MLK holiday. I thought about how 60 days, almost 60 days to this date, he made a conclusion that we have to go for the root causes of health inequities. We have to go after the root causes of these inequities that have essentially been holding us back from becoming among the healthiest nations on earth. And as someone who has been, working with other scholars, looking at the historical roots and the seminal research on health equity, we know that there have been various stages and phases in our history. Of course, those scholars have identified the origin stage, the formative, and the development and expansion stage. And I believe that Compass is now taking us into a new stage, one that will help us to actualize and operationalize health equity when we get this data. As I heard Dr. Ayala mention earlier in our meeting, there's been this exclusive focus on the problem and not necessarily on the solutions. Hopefully I captured your comment accurately. Okay, good. and I think in this new stage of health equity research, it is very clear that further studies are needed to explore the causal pathways between the structural determinants of health and health inequalities. In a review that I had done last summer with 25 other scholars, we looked at both successful and unsuccessful interventions that had been developed. We looked at over 7,000 plus peer-reviewed journal articles that had been published to get a sense of what has worked or what hasn't. And of course, no surprise, there were a dearth of published research, especially looking at structural interventions to glean whether they'd been successful or not. And so we came up with several conclusions throughout that time that I think are in alignment with where you all are heading. Our first conclusion was that data is not where it needs to be, and it's specifically missing a lot for key racial and ethnic minority groups. Native Americans, indigenous populations in particular, are often visible in this. And we also notice in terms of mental and behavioral health and in other prominent themes dealing with emergency preparedness, climate change, and so forth, as was mentioned, that this was also an area that we need to focus on. We know that data helps to unfold the narrative, and without it, proper resources will never be allocated. And sadly, those who are most affected by this issue may not receive the appropriate tools, inclusive of care and supports to overcome those challenges. And then, secondly, we found that interventions are still found in the theoretical realm. And so more work needs to be done to put those interventions into practice. I think Compass is going to help us move that agenda forward in that respect. Our third conclusion from the literature was that more coordinated planning and thoughtful consideration is needed, and that this can be applied in many areas, such as creating actionable research to obtain data whereby those most affected by a problem are involved. Again, I was quite pleasantly surprised to see that Compass actually addresses that issue too. And then lastly, we also looked at the need for additional interventions, specifically on structural interventions, and I think this is going to capture some critical structural interventions. So I think overall, this is a thoughtful and long overdue program needed to advance health equity, and it is my hope that as you all work to stretch the umbrella of inclusivity, when the health equity research hubs are awarded, that we're going to work assiduously to ensure that grantees leverage and utilize this multidisciplinary approach, as well as making sure that we are leveraging, scholars who have oftentimes not been included in this kind of work, and institutions, as we talked about, historically Black colleges and universities, tribal colleges, and so forth, are given an opportunity to work with these folks on these projects. So those are my comments. I think kudos. I share again the enthusiasm and excitement for what is to come. I do think it is transformational, and I applaud the leadership, and would love to hear, Dr. Bynum, some of your thoughts as you're coordinating this project for the inclusion of these institutions, spaces and places, as we've been talking about today, that haven't traditionally been, how that will work moving forward.
Yeah, thank you, Daniel, for those comments. So I want to first start with the first comment about community organizations leading the effort. So it was quite hard for the extramural community to wrap their head around, you can't be PI on the project. This is really for truly community organizations, and we stayed tried and true to that. So it took a little while for the community, the extramural community, our traditional extramural community, to realize that they need to be a partner. They're not leading. And we kind of struggled with the name a bit. At first it was community driven, and that wasn't quite right. So it is community led, to put the leading part front and center. Your second comment about data. So we recognize that in Compass, we have the opportunity collectively to understand impact. So how structural change, the focus on upstream structural intervention, impact health. Not impact health in a particular specific disease and condition, but across different diseases and conditions. And also understanding more collectively on social determinants of health, so those variables as well. So we're going to have common data elements, not only for health outcomes, but for other factors that I think, to your point, will add tremendous value to the field once we get there. So lots of good things to come and happening. So to your question about bringing on board different community partners. So some of the partners that I discussed today are not kind of the traditional partners that you would think of. So they are from universities or organizations that perhaps have not been integrated as well into the fold. So we have some of that already. In addition, there are a lot of different opportunities as the hubs and as the Coordination Center get up and running to bring different organizations at different levels and across sectors into the fold. So we'll be, figuring out how that's going to play out over time. But I think it's an important consideration that, organizations that have traditionally been left out can have value to add to this program. They have been working with communities and integration into the effort in some way does have meaning. So that is yes to come, perhaps the next update.
That's wonderful. And I would just add that I think what you all are doing in terms of this model is going to show the rest of, HHS and other agencies who also provide grants, how you can do this successfully. So I applaud you again in being a game changer in this problem. I am finished with my questions. I want to open up to my colleagues on the council. If you all have any comments and questions as well. Dr. Atkins.
Well, yeah, Daniel, I share your enthusiasm for this. And I'm glad the way that you captured it. And Shalonda, congratulations. That is just, I think this is a game changer, and it's going to really create a new playbook and just reimagining the conversation we have. And, we always say, if you want to change the narrative, you got to change the narrators. And I think you really have done that. And the map, to me is like one of the best things I've seen in my time on this, as part of this advisory council. And I'm just so excited. I'm glad you showed it a couple of times. And I think those blind spots that we have, and you get it, right? We have to kind of really kind of dig into those places and find ways to connect with them. And so, I'm just really excited and energized by this. And made my day. So great work.
Thank you. Thank you so much for that comment. It's very overwhelming, and personally, it can get a little emotional knowing that what we have accomplished already and have the potential to accomplish, and really making sustained impacts on health disparities. And we spent billions of dollars in trying to reduce health disparities, and in many cases, and in most cases, they still exist or persist or have been exacerbated over the course of the pandemic. So I am quite hopeful and excited, and a whole bunch of different emotions going on, but really eager to see what's to come. And again, what's to come is not, only at the 10-year mark. We'll have things that happen along the way that will show progress or lessons learned. I'm not saying that all the interventions are going to be successful, but nonetheless, we will learn quite a bit from the process.
If I could ask a quick.
Oh, yeah, I was just going to see if she could saw your hand, Dr. Beckemeyer, please.
Okay. So just a quick question. Again, I share everybody's enthusiasm. This is super exciting. Dr. Bynum, are you able to give us a little bit of a sneak peek of these common data elements? I'm really curious what those could look like, or if that's not possible yet, or not ready for unveiling.
Not ready quite yet. So, TBD.
Right.
So we understand and recognize that it's important to have the community organizations at CHESI weigh in, right? So it's their projects, they're leading. It should not all be top down from the coordination center. This Compass is focused on community, and we want to stay true to that. We're just in the beginning stages, so we have to develop a process for ensuring that across the 25 projects that what is being proposed in terms of common data element makes sense and is agreed upon throughout the different project teams.
Understood. Great. Thank you.
Any last comments or questions? Appreciate the discussion and the feedback. All right. Well, I'll just echo huge thank you and congratulations to Dr. Bynum for her leadership, to the entire NINR team. There are many, right, at NINR contributing and leading, and it's just as you could, get a glimpse, right? It's a huge effort across the NIH. So many dedicated, committed experts who are creative, committed, and have invested a tremendous amount in this program. So thank you for your support. Thank you, Dr. Bynum. And we will turn to our next agenda item. Our next speaker, NINR Health Science Policy Analyst, Dr. Catherine Tamura, will discuss our recent request for information on future directions for research on violence against women. Dr. Tamura.
Thank you, Dr. Zank. Good afternoon. Today, I will be presenting the results of the Request for Information on Violence Against Women, led by the National Institute of Nursing Research and Office of Research on Women's Health. I want to begin by thanking my colleagues, Dr. Shalana Bynum and Dr. Benjamin Johns, for their fantastic work with me on this project. Next slide. My presentation today will cover a brief background for research on violence against women. Then I'll speak about the request for information purpose and process. And then I'll move to the major themes from the RFI and research examples. Next slide. First, some background. According to the WHO, approximately 30% of women worldwide experience some form of exposure to violence in their lifetime. According to the CDC, about 1 in 2 women have experienced contact sexual violence, physical violence, and or stalking victimization by an intimate partner. And also from the CDC, over 26% of women have experienced completed or attempted rape during their lifetime. Next slide. This request for information established certain definitions for women, violence against women, and social determinants of health to guide the responses, which you can see here. I'll give you a minute to read through them. Next slide, please. Now I will review the purpose and process of the RFI. Next slide. We solicited comments from the public on scientific gaps and research opportunities to address longstanding and emergent factors that perpetuate violence against women. We gathered input to inform research directions to better understand and identify opportunities to address underlying causes that influence women's exposure to violence and to identify approaches to address the health impacts and sequelae of violence against women. These efforts complement ongoing violence research initiatives at the NIH to support research to understand, prevent, and address violence against women and its health impacts. Next slide. The National Institute of Nursing Research and the Office of Research on Women's Health led the RFI and were joined by the Office of Behavioral and Social Sciences, the National Institute of Child Health and Human Development, the Office of Disease Prevention, the National Institute on Minority Health and Health Disparities, and the Sexual and Gender Minority Research Office. Next slide. We received 118 responses from individuals and groups, including scientists, advocates, community organizations, and people with lived experience. 33 organizations submitted responses, which included academic departments, research organizations, and nonprofit or advocacy groups. The responses themselves varied in length from a few paragraphs to several pages long. Next slide. We accepted the responses for 7 weeks. The 3 scientists from ORWH performed the analysis using an NIH program, the RFI tool, developed to aid in analyzing RFI responses. The tool, for your information, is a bit like commercial products such as Atlas TI or In Vivo, and basically allows you to develop controlled vocabularies that facilitate text analysis with a common set of codes. The analysis process begins with open coding or free coding, which we performed over the entire set of responses. Taking that set of free codes, we developed a codebook. The codebook for this RFI was built on 3 main coding areas: scientific gaps in research and violence against women, prevention and treatment, leveraging settings to prevent and treat violence against women, and underrepresented populations in violence against women research. We used these 3 main areas and the codebook and proceeded to formally code the responses. We then developed a summary of the responses and organized them into 9 major themes with recommendations and strategies that identify and address gaps in violence against women research. Next slide, please. And here are the 9 research themes that emerged from the Violence Against Women RFI. Please note that these themes are in no particular order of importance or represent a percentage of responses. The themes are: advance social determinants of health research to understand and mitigate risk, inform policy efforts for broader impact, strengthen measures and methodologies in violence against women research, increase focus on intersectionality, address the health sequelae of violence, incorporate research on violence perpetration, foster family-based research to address the intergenerational transfer of violence, leverage diverse settings to prevent and treat violence against women, and expand focus on disproportionately impacted populations. Next slide. So now we'll go in depth into each one of these themes and provide some examples of potential research that might apply to each. Next slide. The first theme is advancing social determinants of health research to understand and mitigate risk. So here we would consider social determinants of health from the perspective of victimization and perpetration to comprehensively understand the societal and social causes that put people, and especially women, at risk. Some research examples of this would be addressing barriers to violence prevention with a focus on housing and economic instability, lack of childcare, inaccessible transportation, and limited access to domestic violence services and community resources, or increasing the focus on social determinants of health of violence perpetration, such as education, economics, incarceration, and the criminal legal system, and community cohesion. Next slide. The next theme is inform policy efforts for broader impact. The focus here is to inform policy at the local, state, and federal and organizational levels to foster sustained impacts on the prevention of violence against women. For example, research to understand the health impact of policies aimed to prevent and treat violence in institutional and organizational settings like colleges and healthcare settings, or research to inform the de-implementation of harmful policies and programs. Next slide. The next theme is strengthen measures and methodologies in violence against women research. We need to identify new ways to assess the magnitude of and factors that contribute to violence against women, victimization, and perpetration. For example, examine and define risk factors for victims and how well these factors can be used to build protection and resilience, or integrate current data across different federal and state agencies and departments. Next slide. We need to consider intersectionality widely across population groups and subgroups, the life course, and topic areas. For example, increased focus on topic areas and violence against women research like HIV, substance abuse, pregnancy, intergenerational trauma, child and elder maltreatment, and polyvictimization. Or examine intersectionality across systems of oppression such as homophobia, racism, classism, ableism, indigeneity, and immigration to understand how these systems contribute to violence against women. Next slide. The next theme is address the health sequelae of violence. Respondents suggested a need to expand research to focus on health effects of violence against women beyond the acute phase. For example, examine health consequences conveyed. For example, they conveyed consideration for violence against women's research in topics such as hypertension, HIV, cancers, substance use disorders, and depression. And they also included research on sequelae of violence across the life course, especially considering childhood development, adolescence, pregnancy, midlife, aging populations, and menopausal and postmenopausal periods of life. Next slide. A clear and concerted effort is needed to understand the causes of and effective paths to addressing violence perpetration. For example, increase the understanding of underlying factors that foster violence, the immediate circumstances that contribute to violence, and how violence is perceived. Or develop better, culturally relevant, multi-level interventions addressing violence perpetration that consider social determinants of health factors together with family and individual level factors. Next slide. The next theme is fostering family-based research to address the intergenerational transfer of violence. There is a need to assess the interactions, relationships, and health outcomes related to the effects of violence on the family unit across generations. For example, identifying best practices to intervene and prevent violent behaviors within the family unit, or understanding the long-term consequences of childhood exposure to violence, both psychological and the future risk of violence, victimization, and or perpetration. Next slide. The eighth theme is leverage diverse settings to prevent and treat violence against women. Respondents pointed to the need to utilize a variety of settings to promote violence against women prevention and treatment. For instance, utilization of online or virtual settings for violence against women research, especially on the relationship between non-contact forms of violence, for instance, cyberstalking and digital coercion and health, or leverage community groups, which are often overlooked, already involved in violence against women prevention and treatment as potential partners. The final theme is expand focus on disproportionately impacted populations. There's a real need to expand focus on underrepresented populations in violence against women research and populations that are currently represented in the literature but remain disproportionately affected. For example, focus on populations such as American Indian Native, Alaska Native groups, or focus on populations that face structural or legal challenges that place them at greater risk of violence or limit their ability to seek services in healthcare. Here's our contact. Oh, next slide, please. Here's our contact information if you're interested in learning more about this RFI. We will be sharing the final report on our website shortly. Next slide. Thank you.
Thank you, Dr. Tamura. Dr. Johnson, can you start us?
Sure. Yes. Thank you for that presentation and for all the work that went into it. I recognize it's quite a bit, having dabbled in some of the qualitative research methods myself. I know how much is involved in working through that volume of data. So I thought that I was very impressed with the themes that this analysis yielded, and I thought they were clear and lend themselves to actionable areas of research. I also, in terms of some of the process, I found it novel and important that the definition of women also included both cisgender and transgender women, as often the trans women get left out of a lot of these types of discussions, and the rates of violence perpetrated on trans women is really high. And so I commend this effort to include that group. One of the things I was wondering about, and I'll just throw this out, there's a question you can add to it. I think the response rate of 118, I'm just not clear on how, I haven't been as familiar with these RFIs to know if that's robust, is that small, it certainly yielded a lot of qualitative data, but I'm just curious what the response from the broad stakeholder community, how that compares to other RFIs. A couple of comments on some of the themes. I thought that the theme number 3 related to measurement was really important, because we know if we can't measure something well, we don't know whether we're having an impact on it. And I think even as I looked at some of the statistics that were provided in support of this RFI, it gets confusing because, some of the numbers, like 50% of women in their lifetime will have had attempted rape or actual rape, yet only 40% have been exposed to violence. So it just, some of the numbers were confusing. So I think that's where I think this theme about better measuring and understanding what's going on, both in terms of the types of violence and the types of exposure versus experience and victimization. So I think that's a great, a very important theme to guide future research. I also was, I saw alcohol and substance use pop up a couple of times, but not nearly as much as I expected them to. And so I just, I think it popped up in the intersectionality theme and also in the health sequelae theme, but I think it's certainly relevant throughout this. And I know that some of the examples were just that, they were examples and not comprehensive, but it just jumped out to me that that's such an important dynamic or issue in violence research. The another comment about the inclusion of transgender women, or at least female identified women who may not have been assigned female sex at birth. So I think including transphobia and the intersectionality theme will be good. You have homophobia, but not transphobia, and then also including that group in the disproportionately impacted populations theme. I think that was the final theme 9. And I think my other comments, I think you explained them in your presentation. One final comment about theme 8 in terms of leveraging diverse settings. It looked like the examples that were called out were more about those settings as opportunities or settings for victimization through cyberbullying and cyberstalking and other things like that. But I also thought it might be important to elevate the potential of online spaces and social media platforms and outlets as opportunities for support, education, and intervention. So not just opportunities where the violence can occur, but also opportunities where tools can be developed and implemented and evaluated for providing services and prevention for women at risk or experiencing violence. So overall, I was really excited. I could probably go on with this, but that's not what you want to hear. So I'd love to open it up for broader discussion. Thank you for this and the work you've done and the thorough qualitative analysis you did with these data. So thank you. So open it up to my colleagues.
Maybe while people are thinking, John, do you or Catherine want to address the response?
Sure. Actually, 118 is a pretty robust response rate for an RFI. For comparison, we currently are analyzing the RFI on climate change and health, and we've received 50 responses to that. But I've seen across the NIH things range from 50 to a couple hundred. But it depends on how large the community is that's responding. So something like the NIH strategic plan will receive 500 plus, but something that we put out, it's not bad to get 118 for us.
Great, sounds right in line then. Thanks.
Anyone else have comments or questions for the team? Yeah, Dr. Lee.
Yeah, just a quick one. I'm just really thankful that this is back kind of on the plate for consideration, because earlier in Director Zenk's report, I was presented 2 RFAs that expired that were focused on intimate partner violence, and they seemed like just fabulous opportunities. And so I hope some of the things that can come from this being kind of reinvigorated at NIH and NINR in particular is that we'll see more RFAs that come from this. So I'm just really thankful that it's kind of back on everyone's radar.
Thank you for that. Yeah, I do want to thank the team, and it's been a nice example of a collaboration with the Office of Research on Women's Health in terms of shared interests and how we can better collaborate, work together to move science forward. And so it's been nice to have that, and with other institutes and centers. So Dr. Beckemeyer, thank you.
Thank you for this. This is really exciting. I was particularly interested wherever the term prevention popped up, and in particular, I'm really interested to see there be more research around primary prevention. I think that kind of thing is hard to do, but we've got to do it. So to the degree there can be some emphasis on that too. It's great to see, and happy that that's showing up some there too.
Thank you. Well, it's been a day. I mean, I think a super fun day and exciting, and I'm really even more energized now than I was at the beginning, but it's been a lot, I know. So again, appreciate your attention and your contributions and your ideas. So let me pause and just see, if there are questions or comments or announcements or anything that you want to share with one another, with the broader community, or with us.
I have a question, Dr. Zenk, and maybe because this is where my own head is related to the importance of this research that we're trying to promote, and that is the analysis of publications, the analysis of mechanisms. So what activities are happening or could be happening to better understand, say, the impact of the publications that are coming out? So you mentioned at one point, I think in the director's report, that there were now 50 publications that were attributed to the research that was being supported. Is there an additional in-depth analysis that NIH does on these that NINR is anticipating doing? I know it's a big question.
I'm going to let Dr. Grayson jump in after me. So the 50 publications were, sorry if I was unclear, for January of this year, just a snapshot of what has come out. But yeah, I mean, in terms of just trying to understand the impact of our work, right? Like publications and dissemination is part of that. And so we do pay attention. So I'll let John and others jump in.
Sure, Shannon. So that's something that we are constantly looking at, is the publications that are coming out from our supported research. It's something that we monitor on a regular basis. We track there's all sorts of impact factors and what is it, the relative citation ratio. Anyway, there's lots of different things that we can track when it comes to publications. There's no doubt that, despite all the tools at our disposal, assessing impact is always a little bit tricky. You'd like to have something a little more robust than just the number of publications. But unfortunately, sometimes that's the best we have. But it's something that we are constantly taking a look at, and we'll continue to do that.
Other questions or comments or announcements?
On that topic, is there a way to have investigators? I mean, I know we do our reports and things, but, I'm really pleased that some of my own research has been cited in health law in California, like an infection preventionist in every nursing home, and they cited that work. So that's made an impact. It didn't get picked up federally, the nursing, but that was work that NINR funded and has made a difference in policy. And, just a way to capture those things. I don't know how you do that. I know we write about it in our reports, but there might be something in a report about downloads, policy impact, or something that might help you gather that data more easily. Just a suggestion.
Yeah, absolutely. Publications is part of it, but right, our mission is really to impact practice and policy. And so looking at ways and being creative in terms of how to access that data and, using more advanced data analytics, right, to be able to scan and see how we're showing up, where we're showing up in terms of our investigators would be great. But Dr. Hess?
As a program director, I usually asked all of my grantees to send me not only the publications, but if there are any, reports that they have gotten from a community newspaper or, other resources. And so we may want to just highlight that a little bit more sometimes in our newsletters that we're sending out. I think a lot of grantees forget about, let me let NINR know. You automatically assume that you have a publication, it's got the NR number on the publication. Okay, I've satisfied my DOGA, but no, you can do even more. And that came to my mind because I currently just got a video that just came from one of my grantees who sent it to me and said, the community was so excited about this research, I thought I'd share this with you. So I just got it as an email. So I thought, okay, let me share that with you as well. So you'll keep that in back of your mind. And we do. Whatever you send to us, we send to leadership, regardless.
Yeah, absolutely. I'm so glad you jumped in, Karen, because absolutely right. We do rely on our funded researchers to send us information because we use that in a variety of ways. Including to inform decision makers. And so we appreciate it. And if you can help us spread the word, right, if people bring up, just like you did, Dr. Stone, like, hey, I've made an impact and here it is. If you can get folks, including you, to send them in, that certainly helps us advocate for nursing science and inform decision makers.
Yeah, and sometimes these impacts come after the publication or after the grant's done, because we know how long it takes to translate anything, that 17-year translation process, but often it does take a long time.
Yes, so we are never, even when we're done, funding, we'd still appreciate your engagement and your help in terms of sending things our way. So definitely the program directors, and if for some reason that contact's lost, you can always send it to that general email address for the Institute. Other questions or comments or announcements? All right. Well, this has been fun. It is 1:51. So I'm going to adjourn, but let's decide when we want to regroup. Do you want 15 minutes? Do you want 5 minutes? I have to see if I can see head nods of enthusiasm one direction or another.
Why don't we
15?
go to the top of the hour? 10 minutes. Is that okay?
10 minutes. Oh, look at, I love that. Like,
hour.
I love the decisiveness. Okay. We're going to go with 2:00 then.
And it's a different link, or is it the same link? I can't remember.
It is a different link.
Okay. So we sign up. Okay.
Link. Yes. So, okay. So 2:00. Really appreciate everyone's attention. So we're going to adjourn open session at 1:52. And again, if you can join on the other link at 2:00, we'll move from there. So thank you, everyone. See you in a bit.
Thank you.
Thank you.